Let's take a look at the warm-up review, and there's just one question. What are the three different G proteins and what are their downstream effects? So there's GQ, which activates phospholipase C, and then phospholipase C ends up generating IP3 and increasing intracellular calcium. Phospholipase C also generates diacylglycerol, which activates protein kinase C. Then there's the GS protein, which stimulates adenylyl cyclase, and then adenylyl cyclase converts ATP into cyclic AMP, which activates protein kinase A. And the third one is the GI protein, which inhibits adenylyl cyclase, and that decreases cyclic AMP production and decreases protein kinase A activity. And then which receptors use these G proteins? Well, GQ is used by the HAV1 M&M receptors, H1, alpha-1, V1, M1, and M3. GI is used by the MAD2s, M2, alpha-2, and D2. And then all the other receptors we talked about use GS proteins. So that's beta-1 and beta-2, D1, H2, and V2. So that's it for this warm-up. Now let's move on to the lecture.
Hey guys, Dr. Carmichael here, and in this lecture we're going to be looking at seizures. So what's the difference between a partial seizure and a generalized seizure? Well, partial seizures indicate that it's occurring only in one part of the brain, and it kind of says that in the name. Classically, this is in the temporal lobe, and typically these are preceded by an aura. One classic aura is the smelling of burning rubber or burning tires, but auras can be many things like tunnel vision, deja vu, or euphoria. The next thing we need to know is the difference between a simple partial and a complex partial seizure. Again, both of them are staying in one part of the brain. The simple is referring to the absence or alteration of consciousness. So these patients have intact consciousness. A complex partial seizure is when there is an alteration of the consciousness. So what about a generalized seizure? Generalized seizures affect the whole brain diffusely. They can start as a partial seizure and then can generalize. And most seizures do start out in the temporal lobe and then generalize to the rest of the brain if it's going to generalize at all. What are the different types of generalized seizures? Well, there are many types actually. First is the absence or petit mal seizure, and these can present as a staring spell or a blank stare, and sometimes it's associated with the smacking of the lips or slight quivering movements of the facial muscles. And after the seizure, then the person goes right back to doing whatever they were doing and often are not aware that the seizure occurred at all. So, after an absence seizure, patients generally do not have a post-ictal state. Myoclonic seizures present as a brief involuntary twitch of a muscle group or group of muscles. This is what people do right as they're about to fall asleep, only they're doing a lot of that. Tonic or clonic seizures, which are classically what we think about when we think about a seizure disorder, is the grand mal seizure. Here we see stiffness and shaking and the usual convulsive presentation that most associate with a seizure activity. Tonic seizures are characterized as just muscle stiffening without the shaking, and atonic seizures are sometimes called drop seizures. These patients will rapidly lose muscle tone and just fall down. They are often mistaken for syncopal episodes or falling. Sometimes patients will come in complaining of fainting, and in fact, they're just having atonic seizures. Status epilepticus is not actually a type of seizure, but a life-threatening episode of a continuous seizure where the seizure or group of seizures persist for over 5 minutes. This is always considered a medical emergency and can lead to permanent brain damage and death. So what causes seizures? This can vary depending on the age. A large percentage of seizures are idiopathic. In children, a developmental etiology is most common. Other pediatric causes of seizures can include infections, typically with a febrile seizure. Febrile seizures are benign and usually self-limiting. You can also see seizures with trauma and metabolic abnormalities. In adults, we see more common causes due to tumors or stroke, but you can still have the trauma or infection as a cause. As we get even older, stroke becomes the most common cause of seizure. Let's talk about some other disorders that can be associated with seizures. Specifically, let's talk about tuberous sclerosis. So tuberous sclerosis is an autosomal dominant disorder. There is incomplete penetrance and variable expressivity. So one person's tuberous sclerosis may look very different from another person's tuberous sclerosis. Most common mutation you're going to see is the TSC1 or 2 gene. So TSC for tuberous sclerosis. It's not too difficult to remember. Here we see a mutation in the hamartin or your tuberin proteins. And the classic triad for tuberous sclerosis is seizures, intellectual disability, and angiofibromas. Additional findings include hypomelanotic macules. These are referred to as ash leaf spots on the skin, retinal hamartomas, and cortical tuberous that are glioneuromal hamartomas, renal angiomyolipomas, cardiac rhabdomyomas, and astrocytomas. Sturge-Weber is a congenital neurological and skin disorder that is caused by vascular malformations. The most notable characteristic is the port wine stain on the face. The lesion originates in the first and/or second division of the trigeminal nerve. The rash can cover most of the forehead and face. The port wine stain is caused by an overabundance of capillaries and is present at birth. Sturge-Weber is caused by mutations in the GNAQ gene, but is not an inherited disorder. The vascular malformations can also result in glaucoma, seizures, hemiparesis, and intellectual disability, because where there should be brain, there's capillaries. Let's talk about trigeminal neuralgia for a second, because this is another hyperexcitable disorder. It's not really a seizure, it's just a problem with the trigeminal nerve. But the reason we're talking about it here is that we use our seizure meds to treat it. Trigeminal neuralgia is known as tic douloureux, and with this one you're going to have a lightning, horrible pain along the division of the trigeminal nerve, usually at the maxillary, that's triggered by things that like a light touch, wind, bed sheets. It's a very severe pain that's associated with a very light touch, and again we treat this with anticonvulsants like carbamazepine, phenytoin, gabapentin, and topiramate. Refractory cases, there might be a surgical option. Now let's talk about anti-seizure medications. You don't need to know the detailed pharmacology associated with each of the anti-seizure meds. One problem we run into is that many of the anti-seizure drugs can be used for almost any type of seizure. We have the older anti-epileptics like phenobarbital, phenytoin, carbamazepine, ethosuximide, divalproate, and valproic acid. They've been around and have been the primary treatment for decades. But we have a newer generation of drugs, gabapentin, lamotrigine, topiramate, levetiracetam, oxcarbazepine, zonisamide, which are being used with more and more frequency. So you're unlikely to get a question that asks you what's the best anti-seizure drug for a generalized seizure. There just isn't enough evidence for just one drug to be considered first line. There are a few exceptions where there's one or two drugs that are more often used in certain situations, and we're going to cover those. If you look at the mechanism of action of the anti-seizure drugs, you'll notice that they really only work at three different things. First, they block sodium channels. By blocking sodium channels, these drugs are decreasing the generation of action potentials in the neurons. These drugs include phenytoin, carbamazepine, lamotrigine, topiramate, and valproic acid. Second, some drugs will increase GABA activity. Remember that GABA is the chief inhibitory neurotransmitter in the CNS. Again, this will decrease neuron excitability and decrease seizure activity. These drugs include gabapentin, phenobarbital, valproic acid, benzodiazepines, tiagabine, vigabatrin, and levetiracetam. And then the third mechanism is blockade of T-type calcium channels. Again, simply speaking, these drugs decrease the neuronal action potentials. These drugs include gabapentin, ethosuximide, and at very high doses, phenytoin. I would try to remember which group of drug falls into each category, and you'll notice that there are a few that fall into multiple categories. So as I said before, there is a lot of conflicting data on which anti-epileptic is most effective for partial or generalized seizures. There was a large study called the SANAD trial that found valproic acid to be the drug of choice for generalized epilepsy and lamotrigine the drug of choice for partial seizures. But again, I don't think you'll have to make that determination on your test. So we don't spend all day talking about each and every drug and their individual differences. I'm going to go through the study guide questions and that are the highest yield material. First, what is the drug of choice for absence seizures? This is one example where we actually do have an agreement on which anti-seizure drug is best, and that's ethosuximide. If ethosuximide fails, then you can use valproic acid. Next, what is the treatment of status epilepticus? If you have a patient that comes to the ER with a seizure, status epilepticus, the drug of choice is going to be a benzodiazepine, like diazepam or lorazepam, and then you will load phenytoin. Next, what is the treatment of eclampsia? Remember that eclampsia is a seizure during pregnancy, which is associated with elevated blood pressure and again is a very dangerous and high morbidity mortality situation. Unlike status epilepticus, you don't start with the benzodiazepines. If you have eclampsia, magnesium sulfate would be the first thing that you reach for, and in certain cases, if that wasn't sufficient, then you might reach for a benzo like diazepam or lorazepam. The ultimate treatment for eclampsia is immediate delivery of the baby. Once the seizing has stopped, you want to get the baby out as soon as possible. Next, the additional side effects of phenytoin. All the anti-seizure drugs have side effects that include lethargy, ataxia, dizziness, headache, weight gain, and diplopia. Phenytoin has more interesting side effects and they're pretty high yield. The phenytoin side effects mnemonic is phenytoin has given MDs frustration, peripheral neuropathy, hirsutism, gingival hyperplasia, megaloblastic anemia due to decreased folate absorption, drug-induced lupus, Stevens-Johnson syndrome, and fetal hydantoin syndrome. So what is fetal hydantoin syndrome? Well, with this you have a cleft lip, a cleft palate, congenital heart disease, and you can have intellectual disability with developmental delay. Next, which anti-epileptics are teratogenic? So this would be phenytoin, carbamazepine, and valproic acid. And valproic acid is especially known for causing spina bifida when women need to be on even larger amounts of folic acid if they're going to continue to be on one of these anti-seizure medications. Next, what drugs cause Stevens-Johnson syndrome? There's a lot of seizure drugs that can do this. There's another great student mnemonic for this too. Steve Jobs made Apple PCs. Apple PCs, allopurinol, phenytoin, phenobarbital, lamotrigine, ethosuximide, penicillin, carbamazepine, and sulfonamides. Next, what drugs are known to cause agranulocytosis? A helpful way to remember this is to remember that the C's, the carbamazepine, which is the seizure drug, clonazepine, which is an antipsychotic, colchicine, which is a gout drug, and then PTU and methimazole, which are your antithyroid medications, can also cause agranulocytosis. Next, hepatotoxic antiepileptics. The main two to know are valproic acid and carbamazepine. Next, what drug induces the cytochrome P450 system? Your mnemonic is Coronas, Guinness, and PBRs, Pabst Blue Ribbons, induce chronic alcoholism. Drugs that induce P450 are carbamazepine, griseofulvin, phenytoin, barbiturates, rifampin, St. John's wort, and chronic alcoholism. Okay guys, that's for the lecture, but we're itching to do a game show, and we're going to go straight to the end of session quiz after this, but try to yell out the answer before time is up, unless you're in the library, and then just think it really hard. Gingival hyperplasia, Stevens-Johnson syndrome, and a sodium channel blocker. That's phenytoin. First line for an absence seizure, blocks T-type calcium channels. That's ethosuximide. First line for status epilepticus, reversed by flumazenil and increases GABA action. That's the benzodiazepines. Trigeminal neuralgia, hepatotoxic and a P450 inducer. That's carbamazepine. Causes spina bifida, hepatotoxic, sodium channel blocker. That's valproic acid. Now, let's go to the end of session quiz. First question. In regards to seizures, what do the terms partial, simple, complex, and generalized mean? A partial seizure is located in a part of the brain, a specific area, like the temporal lobe. A simple seizure has no alteration of consciousness, and a complex seizure has alterations of consciousness. A generalized seizure generalizes over the whole entire brain. Next question. What are the most common causes of seizures in children? In children, a developmental etiology is most common. Other pediatric causes include infections, febrile seizures, trauma, and metabolic causes. Next question. A 10-year-old child spaces out in class, stops talking mid-sentence, and then continues as if nothing happened. During the spells, there's a slight quivering of the lips. What is your diagnosis? It's an absence seizure. What drugs are known for causing Stevens-Johnson syndrome? That's Steve Jobs made Apple PCs, allopurinol, phenytoin, phenobarbital, lamotrigine, ethosuximide, penicillin, carbamazepine, and sulfonamides. Last question. What are the toxic side effects of phenytoin? Phenytoin has given MDs frustration, peripheral neuropathy, hirsutism, gingival hyperplasia, megaloblastic anemia, drug-induced lupus, Stevens-Johnson syndrome, and fetal hydantoin syndrome. And a quick rapid-fire fact or two. Treatment for the absence seizures is ethosuximide, and the most common cause of seizures outside of the developed nations is neurocysticercosis caused by Tinea solium or pork tapeworms. So if you get a question about somebody traveling from another country to the United States having a seizure, that might be your cause. All right, guys, that brings us to the end of the lecture. Hope you learned something today. We'll see you at the next time.
Hi there, welcome to this warm-up review. Let's get started with the first question. Which nucleus of the hypothalamus fits each of the following descriptions? So this is considered the master clock for most of our circadian rhythms. It's the suprachiasmatic nucleus. Next, regulates the parasympathetic nervous system. This is the anterior nucleus. Next, regulates the sympathetic nervous system. This is the posterior nucleus. Next, produces ADH to regulate water balance. This would be the supraoptic nucleus. And finally, mediates oxytocin production. This would be the paraventricular nucleus. Next question. A 43-year-old man presents with symptoms of dizziness and tinnitus. CT shows enlarged internal acoustic meatus. What is the most likely diagnosis? That would be an acoustic schwannoma in this case. Okay, that's it for this warm-up review. Let's move on to the lecture.
Hello everyone and welcome to our step 1 video on spinal cord lesions. Remember, always lift with your legs, not with your back. Let's get going. Okay, so today we're talking about these spinal cord lesions. If you haven't watched the video on these spinal cord tracts, then you probably should, unless you just really got that material down really well. Now, before we hit the more specific spinal cord lesions, let's go over the motor neuron signs. So what's the difference between a upper motor neuron lesion and a lower motor neuron lesion? Well, the upper motor neuron lesion is a lesion above the anterior horn cell of the spinal cord. And an upper motor neuron lesion is going to cause things like spastic paralysis. You're going to have muscle spasm. You're going to have hyperreflexia. The Babinski reflex might show those toes extending rather than the normal flexion. And then a lower motor neuron lesion affects nerve fibers traveling from the anterior horn of the spinal cord. And with a lower motor neuron lesion, you're going to have flaccid paralysis and atrophy of the muscles, and then muscle fasciculations because there's no nerve signal inhibiting those fasciculations. And there's hyporeflexia because you've lost those reflex arcs as well. All right, so now let's focus on some lesions of the spinal cord. Now first let's start with the motor neurons at the anterior horn. Now this area can be affected by things like polio, the West Nile virus, and by Wernicke-Hoffmann disease. So let's talk about polio first. So polio is not transmitted by aerosol. Polio is transmitted by fecal oral transmission, and it replicates in the oral pharynx before it goes to the small intestine, and then it spreads through the bloodstream where it preferentially goes to the central nervous system. Now it likes to live in these motor neurons of the anterior horn. Because it's living in those neurons, it's actually going to destroy those lower motor neurons. So you're going to have lower motor neuron symptoms with polio, which will result again in that flaccid paralysis that we talked about before. Now patients may also have non-specific things consistent with a viral infection as well, things like fever, headache, malaise, nausea, maybe some abdominal pain, maybe even a sore throat. But the more important neurological findings will include hyporeflexia, weakness, atrophy, and fasciculations, which again are symptoms consistent with that lower motor neuron lesion. Now in some cases you will see asymmetric limbs due to that muscle atrophy. Now, one of the ways you can confirm your diagnosis is to obtain a sample of CSF, and you'll see a lymphocytic pleocytosis and a slight elevation of protein. No change in the CSF glucose, though. If the glucose was really low, that might actually indicate something like bacterial meningitis or maybe tuberculosis. And because polio is a fecal oral virus, you can actually recover this in the throat or in the stool to actually look for that actual virus. All right, so let's talk about Wernicke-Hoffmann disease. So another pretty similar disease is also referred to as spinal muscular atrophy, again also known as Wernicke-Hoffmann disease. So this is an autosomal recessive disease which results in the death of neurons in, again, the anterior horn of the spinal cord. So infants will have severe symmetric flaccid paralysis, and unfortunately most infants will die before the age of 1 year. So remember that spinal muscular atrophy is affecting the anterior horn again. Okay, so another disease that affects the spinal cord is multiple sclerosis. So what regions of the central nervous system does multiple sclerosis preferentially affect? Well, that's a trick question. There's no right answer to that other than the white matter. So multiple sclerosis is a disease of the oligodendroglia of the white matter. Demyelination takes place, which makes it difficult for signals to propagate because you don't have the usual saltatory conduction pathways taking place. Now, multiple sclerosis produces lesions actually throughout the entire CNS. Now, when you look at the brain, you can see old lesions, you can see new lesions that can span, again, the whole CNS, including the brain, the brainstem, and the spinal cord. Now, MS is an autoimmune disease that's more common in women, and especially women in their 20s and 30s, so pretty young. Because this disease can present anywhere in the white matter, it can present in any number of ways as well. So one common presentation is what we call Charcot neurological triad. That's where you have scanning speech, intention tremor, and nystagmus. You might also have internuclear ophthalmoplegia if there is a lesion to the MLF. What was that MLF? That was the medial longitudinal fasciculus. So this is where you have paralysis of the adducting eye on attempted lateral gaze and nystagmus of the abducting eye on attempted lateral gaze again. So you cannot adduct and you have nystagmus with the abducting eye when you're moving that eye laterally. Now, on lumbar puncture, you have a slightly different finding with multiple sclerosis. Here you don't just have a slight elevation of protein in the CSF, you have a very high elevation of protein in the CSF. Now, these are immunoglobulin light chains, and they're going to show up as oligoclonal bands on electrophoresis. Now, MRI is also commonly used for a diagnosis because you can see lesions in the brain and in the spinal cord. All right, so how do we treat this? Well, patients will have exacerbations of their MS intermittently. And when symptoms are severe, these patients will benefit from usual high-dose steroids. So those steroids are effective because MS is an autoimmune disease, so those high-dose steroids for about a week is a pretty common regimen. Other drugs that are helpful include beta interferon, natalizumab, and then symptomatic treatment as well. So what does that mean? Well, if they have bladder incontinence or a neurogenic bladder because of this, patients might need to self-catheterize the bladder. If there's spasticity because you lose upper motor neuron innervation to an area, then you get that treated with maybe a muscle relaxer. And if pain is present, then patients might often need opioids that could be helpful as well. All right, so that's multiple sclerosis. Let's move on to another spinal cord lesion, ALS, so amyotrophic lateral sclerosis, also commonly referred to as Lou Gehrig's disease. So this is a disease of the motor neurons of the anterior horn, just like with polio, and then it also affects the lateral corticospinal tracts. There's two regions here of the spinal cord that are damaged. So as a result, we're going to have both lower motor neuron signs from the motor neurons of the anterior horn damage, and then upper motor neuron signs because of the lateral corticospinal tract damage, which is the hallmark of Lou Gehrig's disease. Patients will present with rapidly progressive weakness, muscle atrophy, fasciculations, spasticity, difficulty speaking, so dysarthria, difficulty swallowing, so dysphagia, and then ultimately difficulty breathing, so dyspnea. So what causes this? Well, you have a defect of superoxide dismutase 1, and this presents with progressive muscle weakness, as we just said, that doesn't get better. Now, riluzole is a treatment that can help a little bit. It can lengthen the survival time by decreasing the presynaptic glutamate release. So glutamate, or glutamic acid, is an excitatory neurotransmitter that can be toxic to the CNS. Next, let's talk about tabes dorsalis. Tabes dorsalis is caused by tertiary syphilis, which is obliterating your dorsal column. So, light touch, proprioceptive information can't get to the upper CNS. Now, as a result, you're going to have a positive Romberg sign. Now, normally, you're taking in vestibular information, proprioception information, and visual information. With Romberg test, you remove the visual information because remember, you have them close their eyes. In tabes dorsalis, you don't have the proprioceptive information. So an individual with tabes dorsalis won't have proprioception or visual information during that Romberg test. All you have is your vestibular apparatus. But two of these things have to work in order for you to know where your body is in the world. So that's why you fall down with that Romberg sign. So that's what's going on with tabes dorsalis. Now, patients with tertiary syphilis may also get the Argyll-Robertson pupil, where the pupil will accommodate but not react to light. There may be absence of deep tendon reflexes, and then sensory ataxia at night. So they'll kind of walk around with a very broad gait, so they're less likely to fall over. Next, let's talk about the anterior spinal artery occlusion. So what happens here? So when you have occlusion of the anterior spinal artery, it's going to affect an area that's roughly the opposite of tabes dorsalis. So that's why we're talking about it here. You're going to lesion just about everything except your dorsal columns. The other areas that are spared are Lissauer's tracts. So you're going to lose your pain and temperature sensation. You're going to lose your motor command bilaterally. And this is going to be both upper motor neuron because you're losing your corticospinal tract, and lower motor neuron because you're losing the motor neurons of the anterior horn. So below the lesion, you get complete motor paralysis, a loss of pain and temperature, and a reflexia as well. But again, your light, pressure, touch, vibration sense is going to be intact with occlusion of the anterior spinal artery. So again, think of this as just the opposite of tabes dorsalis, and that will help you get through this. So how do you get this? It's not very common. Well, the aorta supplies the anterior spinal artery. Therefore, most of the time, this is caused by insufficiencies within the aorta, like aortic aneurysms, dissections, direct trauma to the aorta, and maybe just really bad atherosclerosis. Next, let's move on to syringomyelia. So the word syrinx is a Greek word for tube, like a syringe. So syringomyelia is a cavitary lesion in the spinal cord that fills up with CSF and forms a tube that you can actually see on an MRI. And this typically occurs in the cervical spinal cord. Now, in the video on brain embryology, we discussed Chiari malformations, and a Chiari 1 malformation is where the cerebellar tonsils herniate into the spinal canal. And this can lead to a syringomyelia in the cervical cord. Now, on this MRI, you can see the Chiari 1 malformation up above, and then down in the cervical cord, you can see the syrinx, which gradually expands longitudinally. And as a syrinx cavity dilates, it compresses the nerve fibers around it. Now, typically, a syrinx will compress the crossing fibers of the spinal thalamic tract first, and also the rest of the anterior white commissure, leading to bilateral loss of pain and temperature in the upper extremities. Now, classically, in a distribution kind of like a cape draped over the shoulders and arms. But touch sensation is preserved, and if it gets big enough and extends laterally, it can affect the motor neurons of the anterior horn. And you can actually have weakness and atrophy of the hands as well. So if you see that cape-like loss of pain and temperature sensation in the arms and shoulders, think about syringomyelia. Now, syringomyelia can be caused by spinal cord trauma, developing over the course of months to years, or it can be due to a congenital Chiari 1 malformation, as we said before. And now the last spinal cord problem that we're going to talk is Brown-Séquard syndrome. Brown-Séquard is a complete hemisection of the spinal cord. So you're completely obliterating one entire side of the spinal cord, losing the corticospinal tracts, and you will see ipsilateral upper motor neuron signs. You're also going to obliterate your dorsal columns on that one side, and you'll see ipsilateral loss of tactile, vibration, and proprioception sensation. Contralateral pain and temperature loss will be seen 2 to 3 segments below the lesion. At the lesion, you're going to have ipsilateral pain and temperature loss for 2 or 3 segments. Now, we talked about that with Lissauer tract, so you get ipsilateral loss of sensation at the level of the lesion, and then lower motor neuron signs because of the damage to the anterior horn motor neurons. So that's going to be Brown-Séquard syndrome. That one's a little bit tricky. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. First question, what are the findings of Brown-Séquard syndrome? So we just covered this, so let's do it again. So we get ipsilateral upper motor neuron signs below the lesion, ipsilateral dorsal column loss of the information below the lesion, contralateral pain and temperature loss at 2 to 3 segments below the lesion, ipsilateral pain and temperature loss at the level of the lesion. You also have lower motor neuron signs like flaccid paralysis. All right, so both upper and lower motor neuron signs because the lesion is of the corticospinal tract and the anterior horn, and there's also going to be a loss not only of pain and temperature, but also all sensation ipsilaterally at the level of the lesion. All right, next question. What clinical presentation would lead you to suspect amyotrophic lateral sclerosis as a diagnosis? So remember with ALS, there's a combined upper and lower motor neuron defect with no sensory defect. Next, what are some of the more classic presenting scenarios for multiple sclerosis? So remember that Charcot neurological triad. Remember it was scanning speech, intention tremor, and nystagmus. But also think about a lot of other things, bowel and bladder incontinence, internuclear ophthalmoplegia, optic neuritis. These are very, very common presenting symptoms. Next, what are the classic presenting symptoms of syringomyelia? So remember, this is bilateral loss of pain and temperature sensation in the upper extremities because of dilation of the syrinx, compressing the crossing spinal thalamic tract fibers, crossing at the anterior white commissure. And then in severe cases of syringomyelia, you can affect the motor neurons of the anterior horn and cause weakness in the hand and muscles as well. All right, guys, that's it for the end of session quiz. We do have a few rapid fire facts. First one we have here is conjugate lateral gaze palsy with nystagmus and diplopia during lateral gaze, internuclear ophthalmoplegia. Next, we have degeneration of the dorsal columns. Remember, that's going to be tabes dorsalis that we see in tertiary syphilis. Demyelinating disease in a young woman. Always think about multiple sclerosis. Next, we have mixed upper and lower motor neuron disease. Think of ALS. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time. It's time for the 3-question one for Neuro 16. First question here, what is the initial treatment for ventricular fibrillation? Well, it's going to be CPR, and defibrillation is the big part, so as laid out as the ACLS protocol. The protocol also calls for certain medications, but for step 1, you need to know VFib is a rhythm that needs to be shocked. Next question, what organism is associated with each of the following clues? First one is rabbit hunter. That's going to be Francella tularensis, so if you see rabbits on a test, think of tularemia. Pet prairie dog is going to be Yersinia pestis. I'm not sure how many people have pet prairie dogs. Lymphadenopathy plus a new kitten. That's going to be Bartonella, so that's cat scratch disease. Dog bite is Pasteurella multicida. Next question, what bacterial structure has the following function? First one here provides rigid support to the bacterial cell and protects against osmotic pressure differences. That's going to be the peptidoglycan layer. Space between the inner and outer cellular membrane in gram-negative bacteria is going to be the periplasm. Mediates adherence to bacteria to the surface of a cell. That's going to be the fimbria or the pili. And then protects against phagocytosis is going to be the capsule. All right, that's going to be it for the world. Let's get to that lecture now.
In this video, we're going to be discussing movement. Whoa! Well, not like that. The two structures we're going to cover in this video are the thalamus and the cerebellum, both of which are pretty complicated and both of which have the potential to be really confusing. But the good news is these aren't tremendously high yield. Movement, of course, involves muscle contraction. And the main initiator of muscle contraction is the motor cortex, which sends a signal down the corticospinal tract to the muscles. But before it gets to the corticospinal tract, that signal has to go through the relay station called the thalamus. The thalamus is made up of lots of distinct nuclei with lots of confusing names. In the study guide, there's a question that asks, what portions of the thalamus relay each of the following types of information? Again, this is not terribly high yield for step 1, maybe 2 stars, but it does show up from time to time, so let's go through these quickly. The first bullet is sensory signals from the body via the medial lemniscus and the spinothalamic tract to the somatosensory cortex. This is the ventral posterolateral nucleus, or the VPL. The VPL receives proprioception and light touch signals from the dorsal columns, because remember the dorsal columns in the spinal cord become the medial lemniscus in the brainstem. And it also receives pain and temperature signals from the spinothalamic tract, and it summates all that information before relaying those sensory signals to the sensory cortex. So those sensory tracts both come together in the VPL. The next bullet is trigeminothalamic and taste signals to the somatosensory cortex. So this is the ventral posteromedial nucleus, or the VPM. So pain and temperature sensation from the face is relayed separately from pain and temperature sensation from the body. And one student suggested that you let VPL stand for very painful legs, and VPM can stand for very painful mouth. The next one says relays visual information from the retina to the visual cortex in the occipital lobe. So this is the lateral geniculate nucleus. The optic tracts basically arise from the lateral geniculate nucleus. And then auditory information is relayed from the inferior colliculus to the primary auditory cortex by way of the medial geniculate nucleus. So visual information goes through the lateral geniculate nucleus, and auditory information goes through the medial geniculate nucleus. Now, lots of students like L for lateral and light for visual info, and then M for medial and music or auditory information. The mammillothalamic tract relays information to the cingulate gyrus via the anterior nucleus, which is part of the limbic system, involved in memory and alertness. Communications with the prefrontal cortex, resulting in memory loss if destroyed. This is the medial dorsal nucleus. But I thought this lecture was about movement. So the dentate nucleus of the cerebellum and the basal ganglia send signals to the motor cortex via the ventral lateral nucleus, which is important for the regulation of movement. And then the basal ganglia send signals to the prefrontal, premotor, and orbital cortices via the ventral anterior nucleus. Again, fewer than half of students are going to be tested on this. So if you mastered everything else, then you can spend some time in the thalamus, but I wouldn't make it a huge priority. Now we're ready to talk about the cerebellum and how it's involved with movement. And And again, the cerebellum is complicated and not terribly high yield. So I want to cover this material fairly quickly without getting bogged down in a lot of detail. The cerebellum is involved not in initiating movement, but in fine-tuning and coordinating movement. In your study guide, there's a very abbreviated outline of the flow of information into and out of the cerebellum. The cerebellum receives input from the cerebral cortex and the spinal cord, and those signals go to the cerebellar cortex, and then that sends signals to the deep nuclei of the cerebellum. The deep nuclei are like an integration center for the cerebellum, similar to how the thalamus integrates signals from all over the cerebral cortex. And then the deep nuclei send output signals to the thalamus. We'll cover that output in a moment, but first, the next study guide question asks you to list the deep nuclei of the cerebellum. This is a drawing of the cerebellum cut in cross-section to show the deep nuclei. And our mnemonic for the deep nuclei is fast gerbils exercise daily. We're talking about movement, right? So it kind of fits. Fast gerbils exercise daily. And this stands for the vestigial nucleus, which is the most medial, the globose nucleus, the emboliform nucleus, and the dentate nucleus is the most lateral one. That's the big squiggly looking one. It kind of looks like teeth to me, so think about dentate for teeth. And then sometimes we group the emboliform and globose nuclei together and call them the interposed nuclei because they are interposed or placed between the vestigial and dentate nuclei, which are on the ends. So information flows into the cerebellar cortex, then it goes to the deep nuclei, and then out to the thalamus. And where in the thalamus is this information going? To the ventrolateral nucleus, or the VL. We said the VL relays information from the dentate nucleus to the motor cortex. The next question says, what structure provides the major output pathway from the cerebellum? Well, this is the superior cerebellar peduncle, which carries fibers from the deep nuclei out to the ventrolateral nucleus, specifically the contralateral ventrolateral nucleus. So the big question is, which side of the body is the cerebellum influencing? Or on which side of the body would motor control be affected by a lesion of the cerebellum? Well, the point we're making is that the cerebellum affects ipsilateral body structures. Output from the cerebellum goes to the contralateral thalamus, then to the cortex and down the corticospinal tract, and then the corticospinal tract decussates in the medullary pyramids, and it controls the contralateral side of the body. So it's a double contralateral. It ends up being ipsilateral. It's kind of like a double negative. For example, output from the left side of the cerebellum is going to go to the right side of the thalamus and then up to the right cortex and down the right corticospinal tract until it decussates in the medulla and it controls the left side of the body. So a left cerebellar lesion could show up as loss of coordination in the left arm. Now we're ready to talk about the organization of the cerebellum. You can look at the anatomical organization of the cerebellum, or you can look at the functional organization. Well, let's start with the anatomical organization. Down the middle of the cerebellar cortex is a thin strip called the vermis. Then lateral to the vermis, on either side, are the hemispheres. And deep inside the cerebellum, up against the brainstem, there's a horizontal lobe called the flocculonodular lobe. But on most schematic drawings, like the one in your study guide, the flocculonodular lobe is represented at the bottom. Now, the functional division of the cerebellum is a little bit different. Functionally, each hemisphere is divided into a lateral part and an intermediate part, which is kind of sandwiched between the lateral hemisphere and the vermis on each side. And these intermediate parts are sometimes called the paravermal zones because they are adjacent to the vermis. They're paravermal. The lateral hemispheres are also sometimes called the cerebrocerebellum because they receive inputs from the cerebrum. The vermis and the intermediate hemispheres are lumped together as the spinocerebellum because they receive inputs from the spinal cord, like the spinocerebellar tract. And then the functional name of the flocculonodular lobe is the vestibulocerebellum because it receives input from the vestibular system, the semicircular canals, the vestibular nucleus, and so on. And let's say a word or two about what kind of deficits you would see with various cerebellar lesions. Since the vestibulocerebellum gets input from the vestibular system, you could probably guess that it's involved in balance and equilibrium. So a lesion of the vestibulocerebellum will cause disequilibrium and difficulty maintaining balance, and possibly some truncal ataxia. It can also cause abnormal eye movements, such as nystagmus. The spinocerebellum, which is the more medial parts of the cerebellum, tends to influence the trunk more than the limbs. So a lesion here could cause postural instability. And the upper part of the vermis affects coordination of the legs, so a lesion of the upper vermis can cause a broad-based gait. And then the cerebrocerebellum is the lateral hemispheres, and that tends to control the extremities. So a lesion of the cerebrocerebellum can lead to intention tremor and loss of coordination in voluntary movements. This is why we test for rapid alternating movements, where we have the patient try to flip their hands over on their lap or drum their fingers. They wouldn't be able to do that with a lateral cerebellum lesion. We call that dysdiadochokinesia. I love that word, dysdiadochokinesia. Patients can also have dysmetria, which means they have trouble controlling the distance and speed of movement. That's why we do the finger-to-nose test, where you have the patient try to hit your finger with their finger. We mentioned that lesions of the cerebrocerebellum can cause intention tremors. Well, let's look at the next study guide question, which says, what's the difference between resting tremor, intention tremor, and essential tremor? Resting tremor is tremor that occurs at rest, but it disappears with voluntary movement. This is often associated with Parkinson's disease, which we're going to talk about in another video. Intention tremor is where there's no tremor at rest. The tremor only appears with voluntary movements. When you intend to move, the tremor kicks in. It's an intention tremor. An intention tremor is associated with damage to the cerebellar hemisphere, to the cerebrocerebellum. And then essential tremor is where you tremor both with movement and at rest. There's usually a family history of tremor, and sometimes we call this a familial tremor. Now the next question says, what are the features of essential tremor or familial tremor? These patients can have rapid, fine tremor of the head, hands, arms, and even the voice. The tremor occurs both with movement and at rest. 50% of patients with essential tremor have a family history of tremor, and we can treat essential tremor with beta blockers, which would be the drug of choice, or with the anticonvulsant primidone, or even with clonazepam in worst-case scenarios. But you really don't want to get these patients addicted to benzodiazepines. And patients will sometimes self-medicate their tremor with alcohol because that'll work as well. Now, not all movement disorders stem from cerebellar lesions. Lesions of the basal ganglia can result in hypokinesis and bradykinesia, like we see in Parkinson's disease. And other types of basal ganglia lesions can cause hyperkinesis and chorea. It just depends on which part of the basal ganglia is damaged. For example, if you lesion the subthalamic nucleus, which is part of the basal ganglia, this classically causes hemibolismus, which is an involuntary flailing movement of one arm. So it's hemibolismus. We're going to save the basal ganglia for another lecture. But right now, it's time for the end of session quiz. First question, what kind of information is relayed by each of the following thalamic nuclei? The ventral lateral nucleus relays motor coordination information from the cerebellum to the motor cortex. The ventral posterolateral nucleus, or VPL, relays sensory information from the body to the primary sensory cortex. And the medial geniculate nucleus relays auditory information from the inferior colliculus to the auditory cortex. Remember, M for music. Remember, the lateral geniculate nucleus relays visual information. Next, a patient presents with involuntary flailing movements of one arm. So where's the lesion? That's the subthalamic nucleus. And the last question, what's the difference between essential tremor, resting tremor, and intention tremor? Well, essential tremor occurs both with movement and at rest. Resting tremor occurs at rest and then it disappears with voluntary movement. And intention tremors appear only with voluntary movement. That's it for now. I'll see you next time.
Whoa!
It's time for another warm-up review. Let's get going. What is the initial treatment for ventricular tachycardia when there is no pulse? So we treat pulseless VTach, just like ventricular fibrillation, with CPR until you can immediately get them defibrillated. Next, what is the function of catalase? Well, it's going to degrade hydrogen peroxide into water and oxygen. Next, which portions of the hypothalamus are inhibited by leptin, which are stimulated? So leptin inhibits the lateral area or the lateral nucleus, and it stimulates the ventromedial nucleus. All right, that's it for the warm-up. Let's get to that lecture.
In this video, we're going to talk about the basal ganglia, which is a region of the brain near the thalamus that's vital to regulating movement. The basal ganglia receive a variety of inputs, and then they coordinate all these signals by either facilitating movement or inhibiting movement. So let's talk about how the basal ganglia regulate movement first, and then we'll look at some movement disorders like Parkinson's disease and Huntington's disease. So the cortex decides what part of the body you're going to move, but the basal ganglia regulate the amount of movement. There are 6 basic parts that make up the basal ganglia. There's the caudate nucleus and the putamen, and they function together as a unit called the neostriatum. There's the globus pallidus externa and the globus pallidus interna. There's the subthalamic nucleus. And the last part of the basal ganglia is the substantia nigra, which is Latin for black substance, because when you cut open a brain, the substantia nigra is dark and pigmented. The substantia nigra can be subdivided into the substantia nigra pars compacta and the substantia nigra pars reticularis. We'll talk more about those a little bit later. Now, all these parts of the basal ganglia are communicating with one another and regulating movement by inhibiting and stimulating each other. They use glutamate as an excitatory neurotransmitter, and they use GABA as an inhibitory neurotransmitter. They also use dopamine, which can be either excitatory or inhibitory, depending on what receptors it activates. So take a look at number 4 in the study guide. Now, I don't want you to try to memorize this convoluted pathway, but it's helpful to go through it. And you might try color-coding the connections red or green in your study guide. The thalamus sends an excitatory signal to the cortex, which facilitates movement. The globus pallidus interna sends an inhibitory signal to the thalamus, which inhibits the thalamus. So the globus pallidus interna inhibits movement. The neostriatum modulates the globus pallidus interna in 2 ways. There's the direct pathway, in which neurons from the striatum directly synapse on the globus pallidus interna. So this direct pathway inhibits the internal globus pallidus, so there's less inhibition of the thalamus. In other words, the direct pathway is inhibiting an inhibitor, making the output from the thalamus stronger, and you get facilitation of movement. So the direct pathway facilitates movement. We'll come back and look at the indirect pathway in a moment, but for now, let's look at the substantia nigra. Remember how I said the substantia nigra was divided into 2 parts? Well, the substantia nigra pars compacta sends signals to the neostriatum. These neurons produce dopamine, which acts on the D1 receptors in the direct pathway. Now, that's an excitatory signal, so the substantia nigra stimulates the direct pathway and it facilitates movement. Now we're ready to look at the indirect pathway from the neostriatum to the globus pallidus interna. So the indirect pathway is indirect. It goes through 2 other sites before it gets there. It goes through the globus pallidus externa and the subthalamic nucleus. Let's go through each of these, working backward from the internal globus pallidus. The thalamus is still sending its excitatory signal to the cortex, and the globus pallidus interna is sending its inhibitory signal to the thalamus, which again inhibits the thalamus. So remember, the globus pallidus interna inhibits movement. But the subthalamic nucleus sends an excitatory signal to the globus pallidus interna, which means the subthalamic nucleus is further inhibiting movement. Meanwhile, the globus pallidus externa sends an inhibitory signal to the subthalamic nucleus. So this is disinhibitory overall, because it makes the signal coming from the subthalamic nucleus weaker, which means the signal coming from the internal globus pallidus weaker, so that the excitatory signal coming from the thalamus is stronger, and that facilitates movement. Then, going one more step backward up this indirect pathway, the neostriatum sends an inhibitory signal to the globus pallidus externa. So this is disinhibitory. It's like a double negative. If you inhibit the inhibitor of an inhibitor, the overall result is inhibition. So the neostriatum inhibits the globus pallidus externa, which increases the excitatory signal from the subthalamic nucleus and increases the inhibitory signal from the globus pallidus interna. So this inhibits the signal from the thalamus. So while the direct pathway facilitates movement, the indirect pathway inhibits movement. But now look at the substantia nigra one more time. The substantia nigra pars compacta sends signals to the neostriatum using dopamine again. Now remember, in the direct pathway, dopamine was acting on excitatory D1 receptors, so dopamine was facilitating movement. Well, in the indirect pathway, dopamine is acting on inhibitory D2 receptors. The transmitter's the same, but the receptor's different and the results are different. Dopamine stimulates the direct pathway, but it inhibits the indirect pathway. And since the indirect pathway inhibits movement, dopamine, which inhibits the indirect pathway, facilitates movement. So here's the bottom line, the take-home message. Whether we're looking at the direct pathway or the indirect pathway, dopaminergic signals from the substantia nigra to the neostriatum have the same result, more movement. So there are 2 points that I think are high yield from all this convoluted pathway. Number 1, lesions of the substantia nigra pars compacta cause hypokinesis, less movement. For example, Parkinson's disease is caused by damage to the substantia nigra. So when you knock out the dopamine-producing neurons of the substantia nigra that should normally facilitate movement, you get inhibition of movement, you get hypokinesis. And number 2, lesions of the subthalamic nucleus cause hemibolismus, which is a disorder of too much movement. So the subthalamic nucleus inhibits movement. So if you lesion that nucleus with a lacunar stroke, for instance, and you remove that inhibition, you're going to have too much movement. We'll see that shortly. Make sure you're familiar with both of these points. Now let's talk specifically about Parkinson's disease. Parkinson's disease is a neurodegenerative disorder where there are intracellular inclusions called Lewy bodies inside the cells of the substantia nigra pars compacta. And these Lewy bodies interfere with normal neuronal functioning. So you lose the dopaminergic neurons, and therefore you lose the ability to make dopamine. Normally, these dopaminergic neurons are pigmented with melanin because dopa is a precursor to melanin. As a result, when you lose those dopaminergic neurons, you stop making dopamine, you also stop making melanin. So the substantia nigra is no longer nigra. You have depigmentation of the substantia nigra. Now clinically, Parkinson's disease causes a paucity of movement, a lack of movement, hypokinesia, bradykinesia, or even akinesia. If these patients can't initiate movement, they can't make small adjustments to maintain their balance, they can have postural instability. And this combination of bradykinesia and postural instability can lead to something called a festinating gait, where these patients have trouble initiating walking. And once they actually do initiate walking, once they start going, they have trouble stopping themselves, and they're kind of falling forward. And they're kind of shuffling their feet to keep upright, to keep themselves from falling forward. We call that festination, or a festinating gait. These patients also have a resting tremor called a pill rolling tremor, kind of like they're rolling a pill in their hand. They can have cogwheel rigidity, where you try to passively extend the patient's arm and they sort of have these reflexive contractions that sort of catch like you're ratcheting through a cogwheel. Another classic finding in Parkinson's disease is mask-like facies. They have hypokinesia of their facial muscles, and their faces tend to be sort of frozen and expressionless. I also want to mention one unusual cause of Parkinsonian features, which is a chemical called MPP. So say you were really struggling to make ends meet with your student loans. So you decided to go all Jesse Pinkman and start cooking synthetic meperidine or Demerol to sell on the street. In the process of making that synthetic meperidine, you might be exposed to a chemical called MPTP, or methylphenyl tetrahydropyridine. So your body metabolizes that MPTP with monoamine oxidase to make something called MPP, which is methylphenylpyridinium. And that MPP basically destroys the dopaminergic cells in the substantia nigra by inhibiting the electron transport chain at complex 1. And that destruction of the dopaminergic cells in the substantia nigra can cause Parkinsonian features. Now let's talk about the ways that we can treat Parkinsonism. The patient has lost dopaminergic neurons in the substantia nigra, so one treatment strategy is to increase dopamine production. Now you can't just give dopamine because it doesn't cross the blood-brain barrier. So instead of giving dopamine, we give levodopa or L-dopa, which is a precursor of dopamine that does cross the blood-brain barrier. So when there's more levodopa around, the enzyme dopa decarboxylase can convert it to dopamine. So levodopa is the first-line drug for treating Parkinson's disease. The problem with levodopa is that it doesn't all make it into the CNS. Some of it gets converted to dopamine out in the periphery. That can lead to hypertension and arrhythmias. But probably a bigger side effect is the risk of hallucinations and delusions and psychosis. And tolerance also tends to be a problem. You can have something called wearing off phenomenon, where the hypokinesia comes back in between doses. So levodopa is almost always given with a drug called carbidopa, which inhibits the enzyme dopa decarboxylase in the periphery. So this allows less levodopa to be converted to dopamine in the periphery, and more of it makes it into the CNS. And this reduces the side effects and increases the bioavailability of levodopa. Now what about some other drugs to treat Parkinson's disease? Well, there's a mnemonic balsa, like balsa wood, that's been around forever, but my big problem with balsa as a mnemonic is it doesn't really list the drugs in their order of preferred use, and it leaves out some of the newer drugs. But it might be helpful to help you remember some of the different drug classes and treatment strategies. So the B in balsa is for bromocriptine. So instead of replacing dopamine, you can give a dopamine receptor agonist, like bromocriptine. Now bromocriptine is an ergot drug, which means it's a peripheral vasoconstrictor, and it's going to tend to raise the blood pressure. So more commonly, if we're going to use a dopamine agonist, we use non-ergot dopamine agonists, including things like pramipexole and ropinirole. We also use those drugs to treat restless leg syndrome. Then the first A in balsa is amantadine, which is a drug that used to be used as an antiviral to treat influenza, but most strains of influenza are resistant to amantadine these days. But amantadine helps to increase dopamine release, and it also helps to decrease dopamine reuptake, so the dopamine stays around longer. Then the L in balsa is for levodopa and carbidopa, which we already talked about. The S is for selegiline and other drugs that inhibit dopamine breakdown. So there are two enzymes that break down dopamine, monoamine oxidase and COMT. So monoamine oxidase, or MAO, is an enzyme that breaks down catecholamines, and there's a form of monoamine oxidase called MAOB that preferentially metabolizes dopamine rather than metabolizing norepinephrine and serotonin and other catecholamines. So we can use a selective MAOB inhibitor, such as selegiline or rasagiline, to inhibit MAOB and to keep dopamine around longer. Now, selegiline is particularly helpful in cases of MPTP exposure because of that synthetic meperidine synthesis, because selegiline blocks the conversion of MPTP to the toxic metabolite MPP. So selegiline is the preferred drug for MPTP exposure. Then the other enzyme that breaks down dopamine is called COMT, or catechol O-methyltransferase, which converts levodopa to 3-O-methyldopa. And the drugs that inhibit COMT are entacapone and tolcapone, which always reminds me of the notorious tax evader Al Capone. Anyway, tolcapone and entacapone helped keep levodopa around longer, kind of like carbidopa did. So it's becoming more and more common to use triple therapy of levodopa plus carbidopa plus entacapone. And then the last A in balsa stands for antimuscarinics, such as benztropine. So besides low dopamine levels, Parkinsonism can also be associated with increased levels of acetylcholine. So there are a handful of antimuscarinic drugs, such as benztropine, that we can use in Parkinson's patients that might help to treat some of the rigidity and the tremor, but these drugs don't do much for the bradykinesia. Now, you can also treat Parkinsonism non-pharmacologically by creating a lesion of the subthalamic nucleus. Remember, we said that the subthalamic nucleus is an inhibitor of movement. So if you lesion the subthalamic nucleus and you remove that inhibition, you can facilitate movement. Now, previously this was done by creating a surgical lesion of the subthalamic nucleus, but now they do what's called deep brain stimulation, where they put in an electrode to overstimulate the subthalamic nucleus, and that essentially exhausts the subthalamic nucleus and has the same effect as a surgical lesion, just not quite so permanent. Now let's talk about some disorders not of hypokinesia, but hyperkinesia, too much movement. So there's hemibolismus, which is a wild flailing motion of the arm or the leg, but just on one side. So hemi means half, so this is affecting one half of your body, one side of the body. And I always see the word ball and I think about somebody flinging a baseball around. So it's a big wild movement, not little fine movements like we see with athetosis. Hemibolismus is due to a lesion of the subthalamic nucleus. And again, what does the subthalamic nucleus do? It inhibits movement. So if you stroke out the subthalamic nucleus on the left, you're going to see hemibolismus in the right arm. Now, another movement disorder is called chorea, which is brief, purposeless, non-repetitive jerks of individual muscles. Kind of just little jerking movements. So the word chorea means dancing, like choreography. So these are vaguely dance-like movements, except they're not really repetitive or rhythmic. Then myoclonus is a brief, sudden muscle contraction. Sounds kind of like chorea, but these can be repetitive. And this is almost just like a brief muscle spasm. Just the muscle just contracts on its own. Athetosis is slow, writhing, snake-like or worm-like movements in the hands and the fingers. And then one other movement disorder I'll throw in here is akathisia, which is just an uncomfortable sensation of just needing to get up and move, kind of a compulsion to move. So chorea and hemibolismus and athetosis and myoclonus are all involuntary movements. But when you have akathisia, you're choosing to move because you feel like there's something compelling you to get up and move. Now, we're going to see akathisia again in psychiatry because akathisia can be a side effect of certain antipsychotic drugs. And finally, let's discuss Huntington's disease. Now, the old school name for Huntington's disease was Huntington's chorea. So if you can lock down that phrase in your mind, it's going to help you remember that the movement disorder in Huntington's patients is chorea, those brief, purposeless, non-repetitive movements. So again, it's a disorder of excessive movement. Huntington's disease is an autosomal dominant trinucleotide repeat disorder. Now, the mnemonic for all the features of Huntington's disease starts with the letter C. So it's a CAG, trinucleotide repeat disorder, in a gene that's found on chromosome 4. So the next C is chromosome cuatro. Cuatro is Spanish for 4. It also tends to present in midlife, around age 40. So the Spanish word for 40 is cuarenta, so that's another C. There's also C for chorea, and you can use C for cognitive decline because Huntington invariably causes dementia, as well as depression and psychosis. And then the final C is caudate atrophy, because on the MRI of the brain, you're going to see atrophy of the caudate nucleus and the putamen, which are part of the basal ganglia. Remember, that was part of the neostriatum. So there's death of these neurons because of excessive excitation by glutamate, which acts on NMDA receptors. So just like deep brain stimulation acts like a lesion, excessive excitation of neurons can be neurotoxic. Huntington patients also tend to have increased dopamine in the brain, which explains a lot of the excessive movement. They have decreased GABA, which makes sense because GABA is inhibitory, so they're losing their inhibition. And then they have decreased acetylcholine as well. So how do we treat Huntington's disease? Well, the excess movement is kind of like the opposite of Parkinson's. So for Parkinson's, we want to increase dopamine. So with Huntington disease, we want to block dopamine. And there's a drug called tetrabenazine, which blocks dopamine release. We use that to treat the chorea. If you remember all those C's in chorea, and you remember chromosome quattro, you can link that to tetrabenazine because tetra is Greek for 4. And occasionally, we use neuroleptics like olanzapine and haloperidol to treat Huntington's disease because they also antagonize dopamine. And that can help treat both the chorea and the psychosis that's present. All right, that does it for the basal ganglia. Now let's move on to the end of the session quiz. First question, what are the cardinal features of Parkinson's disease? So you have hypokinesia or akinesia or bradykinesia. You have postural instability. You often have that resting tremor or pill rolling tremor. You have rigidity, like cogwheel rigidity, mask-like facies, and also that festinating gait. Next, a 28-year-old chemist presents with MPTP exposure. What neurotransmitter is depleted? Well, the neurotransmitter depleted is dopamine. Remember, MPTP is converted to MPP, and that destroys the dopaminergic neurons in the substantia nigra. Next, how do each of the following structures normally impact movement? So the globus pallidus interna inhibits movement. The subthalamic nucleus stimulates the globus pallidus interna, so it also inhibits movement. It stimulates an inhibitor of movement. And then the substantia nigra pars compacta stimulates the direct pathway, which inhibits an inhibitor of movement. And the result is that it facilitates movement. And the last question, what neurotransmitters are altered in Huntington's disease? Well, in Huntington's disease, we said you have decreased acetylcholine, decreased GABA, and increased dopamine. And then for our rapid fire facts, depigmentation of the substantia nigra is seen in Parkinson's disease. Chorea, dementia, and atrophy of the caudate and putamen are features of Huntington's disease. And then eosinophilic inclusions in the cytoplasm of neurons are the Lewy bodies, which we see in Parkinson's disease and also in Lewy body dementia, which we're going to talk about in the neuro lecture on dementia. All right, that's it for the basal ganglia. I'll see you next time.
Okay guys, Neuro 18 skeletal muscles, let's do a warm-up. First question, what infections are caused by group A streptococcus? Streptococcus pyogenes. There are different categories of disease. You have the proliferative or pyogenic category of infections such as pharyngitis, endocarditis, skin infections, and bacteremia. You also have the toxin-mediated disease including scarlet fever, necrotizing fasciitis, and toxic shock syndrome. Then the autoimmune-mediated disease, which include acute glomerulonephritis and rheumatic fever. Which gram-positive organism is associated with each of the following statements? The first one is a gram-positive organism that causes scalded skin syndrome. It's Staph aureus. The epidermolytic and exfoliative toxin of Staph aureus causes this. Gray-white membrane in the posterior pharynx of an unvaccinated child is Corynebacterium diphtheriae, causing diphtheria. Pharyngitis resulting in glomerulonephritis is group A strep or strep pyogenes. Most common cause of meningitis is strep pneumoniae. Most common cause of osteomyelitis is Staph aureus. Serious newborn infection, group B strep, listeria, and E. coli are the 3 that you need to know, but E. coli is gram-negative. Now let's move on to the lecture.
Hello everyone, and welcome to our Step 1 video on skeletal muscle. Do you even lift, bro? I didn't want to say anything, but I'm looking a little light. I did legs yesterday, you know, glutes, hammies, quads, calves. Today I'm going to do bis, tris, pecs, traps, but no machines. I mean, I got to hear the weights clinking to know I'm getting swole. Here, I'll do a pec dance for you. You're welcome. All right, so today we're going to talk about muscles, and we'll start with the types of muscle fibers. So what are those different types of muscle fibers? So the types of muscle fibers include type 1 muscle and type 2 muscle. Type 1 muscle is called slow twitch muscle, and this tends to be the red, darker muscles. They're red because they have more mitochondria, and they also have a lot of myoglobin in them. Now they participate in a lot of oxidative phosphorylation. Now examples of great type 1 muscles would be the calf muscles like the soleus and the plantaris. Now your abdominal muscles also have a lot of a higher ratio of those type 1 muscle fibers. And these muscles are great at sustained contraction. So they can contract maybe not very hard, but they can do it for a long time. And then there's the type 2 muscle fibers, and these are the fast twitch. So these muscles are less red because they have less mitochondria, they have less myoglobin present. So these muscles are not very good at electron transport chain stuff, but great at anaerobic glycolysis. And so when you lift weights, anaerobic weightlifting, really hard stuff, that's going to hypertrophy these fast twitch muscles very quickly. So the classic example would be your pectoralis major muscle, your biceps. So those are your different muscle fibers in general. So now let's move on to a muscle conduction to contraction. So a myocyte is a muscle cell. They are long, kind of tubular cells that have the ability to contract. Now each myocyte is composed of myofibrils, and myofibrils are composed of repeating sections of sarcomeres. So the sarcomere is the most basic unit of a muscle. Now the two most important proteins of a sarcomere are myosin and actin. Myosin forms a thick filament, and actin forms a rather thin filament. Now, when you look under the microscope, you'll see these light and dark bands, and these are the myosin and actin overlapping each other. And the sarcomere has a very distinctive pattern that, of course, you need to know for step 1. So, take a look at your study guide and let's label these different zones of the sarcomere. So here, number one. Number 1 is the end of the sarcomere, and it is called the Z-line. So this is the border of the sarcomere. Number 2 is the actin filament. Number 3 is the myosin filament. The myosin is anchored to the Z-line, and that's going to be by number 4, which is the structure called titin. So it's a very large protein. Number 5 is the center of the sarcomere. It is the middle of the sarcomere, so it is often referred to as the M line, M for middle. 6 is the area that's just thick filaments, which is the myosin filament. Now, as you can see, there are no actin filaments overlapping here. So this is referred to as the H band. So think of H as only having huge fibers, and so the H band there is just thick filaments. And as you have contraction of the sarcomere, that H band is going to get smaller. Number 7 is the entire thick filament, including portions that either overlap or don't overlap within the filaments. So that's going to be what's called the A band, and that's going to be a constant area. Then number 8 is the I band, where you have just thin filaments. So I is a very thin letter, and the I band is where you have just thin filaments. And that also would grow shorter with contraction of the sarcomere. Another way to differentiate the A and the I band is that the A looks dark, and dark has an A in it, and then the I band looks light, and light has an I in it as well. So you may have to recognize these lines and area on an actual sarcomere, be able to recognize the Z lines on the outside, the M line in the middle, and then the H zone, A band, and I bands. All right, so that's it for the sarcomere. Now let's talk about how nerve stimulates the muscle cell to contract in another Lewis Notes. So what's taking place here? Well, this is going to be a very simplified version of the physiology. So an action potential travels down a nerve, and acetylcholine is released, which then binds to nicotinic receptors on the muscle. Now the muscle cell depolarizes down the T tubule. And the depolarization eventually gets to a dihydropyridine receptor. And you might recognize that term, dihydropyridine, because of the dihydropyridine calcium channel blockers that end in dipine, like nifedipine and amlodipine. Now, these dihydropyridine receptors are mechanically coupled to a ryanodine receptor on the sarcoplasmic reticulum. So once that action potential hits the dihydropyridine receptor, it stimulates the ryanodine receptor, which causes the sarcoplasmic reticulum to release calcium. Now, calcium is required at the sarcomere level for a muscle contraction. Now, that calcium binds troponin C, which is attached to something called tropomyosin. Now, tropomyosin acts to get in the way of myosin and actin. So in the absence of calcium, tropomyosin is just preventing the binding of myosin to actin, and no contraction can take place. Now, after calcium binds to troponin C, a conformational change takes place in tropomyosin that then allows it to move out of the way. Then actin and myosin are able to interact with each other, resulting in muscle contraction. Now remember, you also have to have ATP on myosin, supplying energy for the myosin head to ratchet along that active filament. All right, we're back. Okay, so going back to what induced the calcium to come out of the sarcoplasmic reticulum, that was the ryanodine receptor. Now I want to focus on that for just a second because there's a specific drug that inhibits the opening of the ryanodine receptor, and that drug is dantrolene. Dantrolene is a drug that's used in the treatment of malignant hyperthermia. One way to get malignant hyperthermia is by the co-administration of inhaled anesthetics with succinylcholine as a paralyzing agent. And what's going on with malignant hyperthermia is excessive muscle contraction. And with excessive muscle contraction, there's going to be a lot of generation of heat. So if you stop the release of calcium from the sarcoplasmic reticulum, then the muscle can't contract anymore. And that's why dantrolene is helpful in that situation. It blocks the action of that ryanodine receptor. All right, so now let's talk about muscle spindles and control of reflex arcs. A little bit tricky here. There's another way to divide types of muscle fibers, and this leads us to a discussion on how we control muscle contraction. The two types are extrafusal muscle fibers and intrafusal muscle fibers. The extrafusal muscle fibers are the functional units of muscle. They're actually doing all the work, all the heavy lifting, so to speak. And we subdivide these into fast twitch and slow twitch, or white and red, which we already talked about before. Now, when an alpha motor neuron from the anterior horn of the spinal cord stimulates the extrafusal fibers, the muscle is going to contract. So far, so good, nothing too difficult. Then the second basic type of muscle fibers are the intrafusal muscle fibers, and they make up muscle spindles. So these aren't here to do any of the heavy lifting. The muscle spindles are proprioceptive fibers that are embedded within the muscle tissue to monitor the length of the muscle. Now, when a muscle stretches, these muscle spindles stretch as well, and that stimulates a 1A afferent. Now, remember, the spinal cord accepts afferents with an A, and then it emits efferents with an E. Or you might remember the efferents exit the cord, E for exit. But these 1A afferents coil around the muscle spindle, and they carry this proprioceptive sensory information from the muscle spindle to the cord and synapse on the alpha motor neuron, causing a reflex contraction. So when you stretch a muscle, the reflex arc causes that muscle to contract a little bit to resist that stretch. So if you tried to pick up a suitcase that's too heavy to lift initially, all that's happening is the muscle is going to stretch. And then that reflex contraction helps to counter that. So the signal is saying to that muscle, hey, this is extra heavy, you need to lift harder. Now, there's another type of sensory organ in the tendon called the Golgi tendon organ, which monitors muscle tension rather than muscle length. Now, one way to remember this is to call it the Golgi tension organ instead of tendon organ. So the Golgi tendon organ sends a 1B afferent feedback signal to the dorsal horn of the spinal cord. They do the opposite of the 1A signal. They oppose the contraction of that muscle. So these 1B fibers stimulate a cell that sends an inhibitory signal to the alpha motor neuron. So when you lift that really heavy suitcase, they send a signal saying, hey, this is too heavy, maybe you should drop it. Then one other thing to be aware of is the gamma loop, which regulates the sensitivity of the muscle spindle. So this signal comes from the brain, and it stimulates a gamma motor neuron, which contracts the intrafusal fiber and increases the sensitivity of this overall reflex arc. So kind of tricky stuff there. So before we move on from muscles, let's cover some pharmacology, talk about some muscle relaxers or relaxants. So these are used for acute muscle spasm, like just a good old-fashioned back strain. We also use these for more chronic muscle problems. Think of things like multiple sclerosis. Baclofen is the first one here. It acts by activating GABA B receptors at the spinal cord level, and it induces skeletal muscle relaxation. Next, we have cyclobenzaprine. So it's a more centrally acting skeletal muscle relaxant. Kind of similar in structure to the TCAs. Also has some similar anticholinergic side effects like sedation and even dry mouth. Metaxalone is another muscle relaxant. We don't know the exact mechanism of action. It may work through kind of general CNS depression. Carisoprodol is another centrally acting muscle relaxant. This one's a little special. This drug is not a barbiturate, but it actually produces many of the same effects as barbiturates, and it's also a pretty addictive drug as well. It can potentiate the effect of narcotics, therefore it's often abused in conjunction with narcotic use. In general, we're trying not to use this drug much anymore. All right, so now let's talk about some reflexes. I'm not going to spend much time talking about the reflexes we test clinically because they're pretty low yield, but it might be worth reviewing the nerve roots you're testing with all of these. So let's start at the bottom here. The Achilles reflex is going to test the S1 nerve root there. The patellar reflex is going to test the L4. The triceps reflex is going to test the C7. And then the biceps reflex is going to test the C5. And then while we're on the subject of reflexes, let's talk about the newborn reflexes or primitive reflexes. We use these to determine the health of a neonate's central nervous system. So first we have the rooting reflexes where you stroke the side of the mouth or the cheek, and then it's going to cause the baby's head to kind of turn in the direction in search of food for the nipple. That's called rooting. Next, we have the sucking reflex, is when you place your finger on the roof of the baby's mouth and they start sucking the finger. So these reflexes, again, are going to ensure that the newborn will be able to nurse right away. The palmar reflex is where you just stroke the palm of the hand and then they kind of grab on reflexively. The plantar reflex, or probably more commonly referred to as the Babinski reflex, is where you stimulate the sole of the foot and that causes the toes to fan out and the great toe to dorsiflex. And that goes away eventually, and if you stroke the sole of an adult's foot, the toes will actually plantar flex. But we check for this Babinski reflex in adults sometimes to assess upper motor neuron function. If you do this to an adult and the toes fan out, that suggests an upper motor neuron problem. And then we have the Gallant reflex, which is where you hold the baby on his or her stomach face down, and then you stroke along one side of the spine, and the baby will kind of flex laterally toward the side. But my absolute favorite one is the Moro reflex, where you lay the baby kind of flat on the table, you kind of lift them up by the arms just an inch or two, and then you kind of let them drop gently back to the exam. And the reflex kind of responds as they kind of abduct and extend the arms, and when they flex that, it's kind of interesting, like they're trying to give you a hug. It's like their response to falling is to reach out and grab a hold of something. Another way to test this is to hold the baby kind of like this, and then kind of drop the head down a little bit. You don't drop the baby on its head, but just lower the head quickly, and then you'll see that kind of arm go up as well. Parents don't like that one very much, though. Now, I've also linked some YouTube videos that demonstrate a lot of these reflexes as well. All right, guys, that's it for the lecture part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. First question, which two muscle receptors are responsible for opening the sarcoplasmic reticulum in response to depolarization? So we got to think about the dihydropyridine receptor and then the ryanodine receptor. Next, what drug prevents the release of calcium from the sarcoplasmic reticulum of skeletal muscle? You got to think of dantrolene. Next, what are the differences between type 1 and type 2 muscle fibers? Remember, the type 1 muscle is called slow twitch muscle, and this tends to be your red, darker muscles because of more mitochondria and myoglobin. They participate in a lot of oxidative phosphorylation, and these muscles are great at sustained contraction. Type 2 muscle fibers are the fast twitch muscles. They are less red because they have less mitochondria and myoglobin. They do a lot of anaerobic glycolysis. Next, what are the differences between 1A afferent motor pathway and 1B afferent motor pathway? So the 1A afferent comes from the muscle spindle, stimulates the alpha motor neuron so that you get some muscle contraction. The 1B afferent comes from the Golgi tendon organ, and it eventually inhibits muscle contraction. And then we have a rapid fire fact: toe extension upon stimulating the sole of the foot with a blunt instrument. So that's going to be the positive Babinski reflex, or a positive Babinski sign. Often, to avoid confusion about what's positive and what's negative depending on the age of the patient, sometimes we'll just say that Babinski is down going, which would be normal for an adult, or we'd say Babinski is up going, which is abnormal for the adult. And you would need to say which side, like Babinski is up going on the left. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Let's go over the 3-question warm-up for Neuro 19. First question: which gram-positive organism matches each of the following statements? So an infant with poor muscle tone, that's going to be Clostridium botulinum, and botulinum toxin. Diarrhea after using antibiotics, think about Clostridium difficile. Respiratory distress in a postal worker, what we're going for here is Bacillus anthracis. Right after 9/11, there was this huge concern that there was going to be inhalation anthrax spread through the postal service as an agent of biological warfare. Then otitis media in children is most commonly strep pneumo if it's bacterial at all. Now, lots of time, otitis media is a viral infection. And then cellulitis is most commonly going to be Staph aureus and strep pyogenes, or group A strep. Next, what's the classic presenting symptom in a patient with Lyme disease? So classic presenting symptom is erythema chronica migrans, which is an expanding bullseye rash with central clearing. And the last one, what's the function of macrophages in the spleen? So macrophages in the spleen remove encapsulated bacteria, and they remove dysfunctional cells like dysfunctional red cells. Now let's get started with the lecture.
Hello everyone, and welcome to our Step 1 video on the upper extremity nerves. Guys, you've been studying forever by now, and by this time, you're now in one of about 3 groups. The first group consists of students, though fatigued, are focused and are now kicking it into the next gear to keep the learning going. Group 2 consists of students who are on the brink of a freakout. Their brain is at capacity and they're not feeling too good. Don't say high yield or they'll pop. Then the third group are the ones that have already given up and are now watching these videos as a part of a drinking game. Anytime I say moving on, they take a drink. I'm told I say that a bit. So, all right, moving on. So today we're going to cover the brachial plexus and the upper extremity nerves. And before we talk about the brachial plexus, we need to talk about the anatomy of the neck, because it's actually pretty important to know for step 1. Now, it's always hard to teach anatomy because most of the time we have to say, hey, look at that. You should probably remember that. So you may need to break out the old anatomy book again, brush away the cobwebs. So our strategy is not to waste a bunch of your time showing you every anatomy picture that we can find and tell you, well, that's important, remember that one. Instead, we're going to try to hit the highest yield anatomy and then cover the pathology associated with that anatomy. So let's move on to the neck. Well, first of all, one way to organize the neck is to separate into 2 distinct and different triangle regions, which are separated by the sternocleidomastoid muscle. So the first thing you need to do is locate that sternocleidomastoid muscle. So that's separating the posterior triangle from the anterior triangle. Well, what forms the posterior triangle is the sternocleidomastoid, the trapezius muscle, and the clavicle. Sternocleidomastoid, trapezius, and clavicle. So what is in the posterior triangle? Well, you have the brachial plexus. Near the clavicle, specifically at the mid-clavicle, you have the subclavian vein. Also in the posterior triangle, you have the external jugular vein. And then a muscle that presents in the posterior triangle overlaying the posterior triangle is the inferior portion of the omohyoid. So that's also on the posterior triangle. So let's go on to the other side of the sternocleidomastoid and talk about the anterior triangle of the neck. The anterior triangle is formed by the midline of the neck, or the trachea, and the mandible on the superior aspect, and then on the lateral aspect, again, that sternocleidomastoid. So what do you have in this region? Well, up in the superior aspect, you have the posterior digastric muscle and the anterior digastric muscle. In the midline of the neck, you have your sternothyroid muscle. Lateral to that, you have the sternohyoid muscle. And then lateral to that, the superior omohyoid muscle. And then as that muscle goes down inferiorly and goes into the posterior triangle, it then becomes the inferior omohyoid that we talked about before. All right, so we just saw the brachial plexus in the posterior triangle. The brachial plexus is a network of nerve fibers that originate from the spine and ultimately result in the named nerves that we know that supply sensation and muscle innervation to the upper extremity. So now let's label the brachial plexus. This is a 4-star topic. Most of you are going to get a question on this. This is also going to be in the study guide as well. So the brachial plexus comes from C5, C6, C7, C8, and T1 nerve roots. And then the roots become your trunks, which then become your divisions, and then your cords. And then finally, the terminal branches. And so there's a few different mnemonics that you can use to remind you of this. The one that we've used around here is Randy Travis drinks Coors beer, and that's gonna again go for roots, trunks, divisions, cords, and then branches. But whatever works for you, but let's go ahead and take a look at these. Okay, so let's label this brachial plexus. First one here, we have letter A. Letter A, that's going to be the long thoracic nerve. The long thoracic nerve innervates the serratus anterior muscle. Now, one good way to remember the serratus anterior is that innervation here for that long thoracic nerve is the word SALT, S-A-L-T. So S-A for serratus anterior, L-T for long thoracic. Letter B is the suprascapular nerve, which is coming off of the superior trunk, and the suprascapular nerve innervates the infraspinatus and supraspinatus. Letter C, coming off of the lateral cord, is the lateral pectoral nerve, which innervates the pectoralis major. Letter D is the upper subscapular nerve, which innervates the subscapularis. Letter E is the thoracodorsal nerve, which innervates the latissimus dorsi. So these are all coming off of the posterior cord. Letter F is the lower subscapular nerve, which innervates the teres major. And now moving on to the terminal branches. G is your musculocutaneous nerve. It innervates your biceps, coracobrachialis, and brachialis, the main flexors of your arm. Letter H is going to be your axillary nerve, which innervates your deltoid and teres minor. Letter I is your radial nerve, which innervates your extensors and your triceps. If you injure your radial nerve, then you're going to get a wrist drop. Letter J is your median nerve, which innervates your pronators and your thenar muscles of the hand. And then letter K is your ulnar nerve, the little baby nerve of the hand. It innervates your interosseous muscles and your hypothenar muscle, so your little pinky muscle. All right, so I bet you got all of those right. Well, maybe a few of you don't have it quite memorized yet, so we better go through this again in a Lewis Notes. All right, everyone, welcome to a Lewis Notes. We just got done labeling the brachial plexus, but we're going to do this again a different way. I want you to draw it out yourself, because I think if you draw it out yourself, you're going to learn it even better. So we're going to go through this together. We're going to go slowly, because the more times we go through this, you're going to get it. And then we're going to label it again in end of session quiz at the end. So let's go through this together. I want you to set up your piece of paper, put at the top roots, trunks, divisions, cords, branches. Randy Travis drinks cold or Coors beer. Sometimes the branches are referred to as the terminal branches, but we're just going to use branches here. And then on the left side, we have C5, C6, C7, C8, and T1. All right, so starting with the roots, I want you to make a triangle right here, and then on C7, it's just a straight line, and then on C8, T1, we do another little triangle-looking thing here. Now, the hardest thing about the roots is that there's this weird nerve that's going to come off right here. It's going to get multiple innervations here. And what's going to be that one that goes right there? Do you guys remember that one? Remember, that's going to be your long thoracic nerve. So you're going to take long thoracic and you're going to put that one right there. So let's go back to our drawing now. So if we go back to our drawing, we're going to go to our trunks area. So if we go to our trunks, we go across there, we go across there, we go across there. There's not a whole lot to remember on the trunks. There is one on this top one right here. Do you guys remember which one that was? That was the suprascapular. So I want you to write in suprascapular right up here. Moving along, divisions. Thank goodness we don't have to know anything about divisions. You just keep on rolling right through there until we get to our cords. Now our cords is a whole different scenario. We got a lot of cords that we have to remember here. So let's go through here like this. Let's go like here like this. So in our cords at the top here, we've got one up there. Which one is that going to be? That's going to be our lateral pectoral. So let's grab our lateral pectoral and let's put that right up there. Now our middle one is going to be our most difficult cord section. We've got 3 over here. So you're going to have 1 there, you're going to have 1 here, you're going to have 1 here. What are going to be the ones that we connect here? So remember, the first one is the upper subscapular. So the upper subscapular is going to go over here. The next one is the thoracodorsal. So the thoracodorsal is going to be the middle one right there. And then the third one is going to be the lower subscapular. So the lower subscapular is going to go down right there. We don't have a whole lot of room there, but we'll just kind of sneak it in. On the bottom section, there's nothing to remember. Now, the next section that we're going to do is our branches. So the branches get a little complicated as well. You're going to have a little break right there, and then you're going to have it go all the way down, and then you're also going to have sort of this V connection right here, and you're going to get another nerve right there. So let's put all these things in. So in this little V right here, we have our axillary nerve. On the bottom part of that, we have our radial nerve that's going to go right there. On our top, at the very, 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 very end here in our terminal branch, we have the musculocutaneous nerve. In the middle here, it's easy to remember because it's the median nerve that's going to go right there. And then our bottom, the ultimate nerve, the ulnar nerve, is going to be the one that goes in right there. So if you can write this out yourself maybe a couple of times, I think it will stick in your brain. And then we'll actually do this again in our end of session quiz. And now for our second review of the material. We're going to add in some detail to the anatomy, and we're going to start to learn the muscles and their functions. Again, don't panic if you don't get it all now. We'll cover this again in the next video, and we'll cover the pathology there as well. So the first one here is the long thoracic. So this is going to innervate the serratus anterior. Remember the mnemonic SALT. Now the serratus anterior is a muscle that originates on ribs 1 through 8, and then inserts at the medial border of the scapula. So the muscle's just below the armpits. It holds the scapula onto the thorax. Next, we have the suprascapular, and this is going to innervate the infraspinatus and the supraspinatus. Now these are parts of the rotator cuff. Now the infraspinatus externally rotates the humerus and stabilizes the shoulder joint. The supraspinatus is going to act to abduct the arm. Next, we have the lateral pectoral nerve. So this is going to innervate the pectoralis major. So it makes up the bulk of the chest muscles. Now it has several actions, including flexion, adduction, and medial rotation of the humerus, and it acts to keep the arm attached to the trunk. Next, we have the upper subscapular, innervating the subscapularis. So this is a triangle-shaped muscle that fills the subscapular fossa. It inserts into the lesser tubercle of the humerus and the front of the capsule of the shoulder joint. The subscapularis acts to internally rotate the arm. Next, we have the thoracodorsal. It's going to innervate the latissimus dorsi. Now, the lats are responsible for extension, adduction, transverse extension, and flexion from an extended position, and then internal rotation of the shoulder joint. So that's a mouthful. So how are you going to remember all that? Sometimes look at the weightlifters and see what exercises they do to work out a certain muscle. That gives me a better idea of what that muscle does. So to work out the latissimus dorsi, you can do pull-ups, or even better, lean over and pull up a bar or a dumbbell. Next, we have the lower subscapular nerve. This is going to innervate the teres major. So it originates on the dorsal surface of the inferior angle of the scapula and then inserts on the medial lip of the intertubercle sulcus of the humerus. Now this muscle medially rotates and adducts the arm. Next, we have the musculocutaneous. That's going to innervate the biceps, the coracobrachialis, and the brachialis. So these are the major flexors of the arm and forearm. Next, we have axillary nerve. That's going to take care of our deltoid and teres minor. The deltoid acts to abduct the arm, especially along the frontal plane. The teres minor acts to laterally rotate the humerus. Next, we have the radial nerve. So that's going to be your extensors and your triceps. So the triceps and the extensors act to extend the forearm, and we'll cover this in even greater detail in the next video. Next, we have the median nerve, so the pronators and the thin arm muscles of the hand here. So these act to pronate the forearm. It has other functions in the hand, and we'll cover again that in the pathology in the next video. Ulnar nerve, so flexor carpi ulnaris, interosseous muscles, and your hypothenar muscle. So in the forearm, the ulnar nerve acts to flex and adduct the hand. And the hand, again, we'll cover in more detail when we go through the pathology. Okay, so that's another review of the upper extremity nerves and the muscles, and we've also labeled the brachial plexus. All right, so make sure that you can label that brachial plexus and know what muscles are innervated by those nerves of the brachial plexus. And while we're talking again about the brachial plexus, I want to talk about one specific lesion of the brachial plexus, which is an injury to the superior trunk or an injury to the C5 and C6 nerve roots. And that's going to give rise, again, to that superior trunk. Now, so if you injure that area, that causes Erb-Duchenne palsy, also referred to as waiter's tip syndrome. And so what causes this? Well, you can injure this area by trauma. The shoulder or neck can be traumatized, leading to kind of a violent stretch of the nerves of the superior trunk. Now, the most common scenario is seen with dystocia during newborn delivery. The infant's head and neck are kind of pulled towards the side at the same time as the shoulders pass through the birth canal. Now, it can occur with excessive pulling on those shoulders during a cephalic delivery as well. So you can also see Erb-Duchenne palsy in newborns with clavicle fractures, even if it's not due to a dystocia. Dystocia occurs more often, again, in large for gestation babies, so be on the lookout for that on your test. So how does this present? Well, the paralysis can be partial or complete depending on the damage. Sometimes we see just kind of bruising or stretching of the nerves, and sometimes we see complete tearing of the nerves. Now, the most commonly affected nerves are going to be the nerve branches for the suprascapular nerve, the musculocutaneous nerve, and the axillary nerve. So with those nerves being affected, what are you going to see here? Well, there's going to be loss of sensation in parts of the arm and atrophy of the deltoid, the biceps, and the brachialis muscles. The limb is going to hang down by the side, so you have paralysis of your abductors. It's also going to be medially rotated, so you have paralysis of the lateral rotators, and the forearm is pronated, so you have loss of the biceps. So it kind of looks like a waiter asking for a tip kind of behind the back in kind of like a little subtle way. Now, usually infants will regain full function if there's only bruising or stretching of those nerves. Now, if there's complete tearing, unfortunately, then sometimes the symptoms are permanent. Now, another portion of the brachial plexus that can be injured is the inferior trunk, so that's C8 and T1. So what happens if you injure the inferior trunk? Well, you get Klumpke's palsy, which is much less common. Now, this injury can again occur during a difficult delivery. So this can result when there is traction on an abducted arm. So if the infant is pulled from the birth canal by an extended arm kind of above the head, that's when this can happen. It can also happen to an older person who, for example, tries to catch him or herself by a branch while falling from a tree. Now, when an injury to C8 and T1 occurs, there is subsequent paralysis of the intrinsic muscles of the hand. So you've got to think about the interossei, the thenar, and the hypothenar muscles. There's also potential paralysis of the flexors of the wrist and the fingers. Now, the classic, very severe presentation is going to be a supination of the forearm with wrist and fingers flexed. But you can also see wrist and finger weakness leading to kind of a virtually flail hand and wrist. Now, there's also going to be sensory deficits on the medial side of the arm, forearm, and hand. All right, that's going to be to the end of the video part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through the answers together. All right, first question. We're going to do another big labeling here. This is a big part of this lecture here. So let's go through this again. Letter A, that's going to be the long thoracic nerve. Letter B is the suprascapular nerve. Letter C, coming off of the lateral cord, is the lateral pectoral nerve. Letter D is the upper subscapular nerve. Letter E is your thoracodorsal nerve. Letter F is the lower subscapular nerve. Letter G is your musculocutaneous nerve. H is the axillary nerve. I is the radial nerve. J is in the middle, it's your median nerve. And then letter K is going to be the ulnar nerve. All right, next question. What are the symptoms of a lesion to the C5 and C6 nerve roots? You got to memorize the C5 and the C6 part of this. So this is going to be our regular old Erb-Duchenne palsy, which would show symptoms of paralysis of the upper extremity, including paralysis of the lateral rotators, biceps, and abductors. Remember that waiter's tip. So that presentation again is the arm hanging limp at the side, medial rotation, forearm pronated, and again, buzzword waiter's tip. All right, next question. What are the symptoms of a lesion to the inferior trunk of the brachial plexus? Remember, that's our Klumpke's palsy. So those symptoms would be things like sensory deficits of the forearm and hand on the medial side, upper arm as well. You're also going to see atrophy of the hand muscles, so the thenar, hypothenar, and interosseous muscles. All right, so then we have one rapid fire fact. You should know this one by now. Newborn with arm paralysis following a difficult delivery. First, think of Herb Duchenne palsy. You might have Klumpke on there, but Herb Duchenne is going to be far more common. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Let's do the warm-up for Neuro 20. First question, what patients are susceptible to Listeria monocytogenes? So think about neonates and also immunocompromised patients. So Listeria can cause neonatal meningitis, and also it can infect the amniotic fluid, and that leads to spontaneous abortion. Next, what name is given to red cells that have been partially digested by splenic macrophages? Well, these are called bite cells, or the fancy official name is degmocytes. So the macrophages remove the denatured hemoglobin in the patients who have that G6PD deficiency, and the result is red cells that look like a bite's been taken out of them, so they're called bite cells. And the last one, which nerve is being tested with each of the following reflexes? So the biceps reflex tests the C5 nerve root, triceps reflex tests C7, the patellar reflex tests L4, and the Achilles reflex tests S1. Okay, now we're ready for the lecture.
And now, it's time for the ulnar nerve circus featuring the high-flying interosseous. Thank you. Hello everyone and welcome to our Step 1 video on the upper extremities, part 2. Okay, so in our last video, we attempted to memorize that brachial plexus, and we started learning about the nerves of the upper extremity and which muscles they innervate, and we started learning about some of the motor innervations as well. Now, in this lecture, we're going to go a bit deeper into the nerves of those upper extremities, and we'll also cover the high-yield pathology. Now, some of this is review from the last video, but that's good because this stuff is pretty dense, and repetition is the way to go. But again, we're not going to cram weeks of anatomy into 20 minutes. You may still need to sit down with your anatomy book and re-memorize the anatomy of the upper extremity. All right, so I'm going to go nerve by nerve, and we're going to start with the radial nerve. So the radial nerve is an important nerve in the upper extremities, obviously. The radial nerve innervates the medial and lateral heads of the triceps brachii muscle. Now, new evidence shows that the long head of the triceps is actually innervated by the axillary nerve. But the triceps in general are the major extensors of the forearm. Now, there is a deep branch of the radial nerve, and it innervates the supinator and brachioradialis. These act to supinate the forearm. Now, the brachioradialis doesn't follow the rules of the radial nerve very well, though. Now, most of the muscles act to extend, but the brachioradialis again acts to flex the forearm, and it can pronate a little as well, depending on the position of the arm. The deep branch also innervates the extensor carpi radialis longus, which is just next to the brachioradialis muscle, and it's going to act to extend the wrist. Now, the radial nerve distally will become the posterior interosseous nerve, which is going to act on multiple muscles to extend the fingers and the hand. Now, a couple of examples include the extensor digitorum and the extensor pollicis longus. So, when you think of the radial nerve, remember that it generally acts to extend the forearm, the wrist, and the fingers. Now, another hint for the muscles that the radial nerve innervates is the mnemonic BEST, B-E-S-T. For again, that's going to be brachioradialis, extensors of the wrist and fingers, supinator, and triceps. So that's BEST. So what about sensation? Well, branches of the radial nerve provide cutaneous innervation to the skin of the posterior arm and the back of the hand. Now, what about pathology? Now, one scenario where you might compress the radial nerve is with Saturday night palsy. Here we see radial nerve compression against the spiral groove of the humerus. So if you're passed out with your arm over a chair on Saturday night, as I often am, for hours and hours because you're drunk, then you would compress the radial nerve. Now, as a result, you would have weak wrist and finger extension, so you can get that wrist drop, a numbness of the back of the hand and wrist, and a weak brachioradialis reflex. All right, so you've lost your ability to extend. Now, when you hear wrist drop, then you certainly need to think radial nerve injury. Now, another injury that tends to injure the radial nerve is a fracture of the shaft of the humerus. The radial nerve tends to get damaged with a fracture along the shaft of the humerus. And make sure you see shaft in the question. Don't get this mixed up with a fracture of the surgical neck of the humerus, because that's a different injury and we see a different nerve involvement. All right, so now let's move on to the ulnar nerve. Now, in the forearm, the ulnar nerve innervates the flexor carpi ulnaris and the flexor digitorum profundus. Now, the flexor carpi ulnaris will flex and adduct the wrist. The flexor digitorum profundus will flex the wrist and flex the fingers. Now, there are multiple innervations in the hand. Now, first, we have the hypothenar muscles that act to control the hand and the little finger. It also innervates the third and fourth lumbricals, which flex at the MCP joints, and it's going to extend the interphalangeal joints. So remember this one, because we're going to come back to that with some pathology. Now, it also innervates the interosseous muscles, which act to abduct and then also adduct the fingers. I would have a tough time performing my circus act without the ulnar nerve and the interosseous muscles. And finally, it's going to innervate the adductor pollicis, which acts to adduct the thumb. All right, so let's cover sensation. The ulnar nerve only provides sensation to the hand. It will cover the fifth digit and half of the fourth digit and the corresponding part of the hand. So the medial side of the palm and the dorsal hand. Now for pathology. Now, if you know the innervations, then you can reason out the pathology. The flexor carpi ulnaris and the flexor digitorum profundus work to flex the wrist and the fingers. So if you have a more proximal injury, then you get loss of wrist and finger flexion. Distally, with the ulnar nerve injury, we see what's called the ulnar claw. So remember that the third and fourth lumbricals acted to flex at the MCP joint and extend at the interphalangeal joints. So if we lose the third and fourth lumbricals, then the fourth and fifth digits will be hyperextended at the MCP joints and then flexed at the IP joints. With the interosseous muscles impaired, there will be more difficulty with abducting and adducting the fingers. You may also see hypothenar wasting as well. All right, let's move on to the median nerve. So the median nerve innervates almost all of the flexors of the forearm and many of the pronators as well. The pronators include the pronator teres and the pronator quadratus. The flexor carpi radialis and the palmaris longus will flex the forearm. The flexor digitorum superficialis and the lateral half of the flexor digitorum profundus will flex the wrist and the fingers, and the flexor pollicis longus will flex the thumb. So overall, think flexion and pronation with the muscles innervated by the median nerve. Now in the hand, the median nerve supplies the first and second lumbricals, which will flex the MCP joints and extend at the IP joints. The median nerve also innervates the thenar muscles, which includes the opponens pollicis, the abductor pollicis brevis, and the flexor pollicis brevis. What about sensation? Well, sensation from the median nerve will cover the lateral palm in the first 3.5 digits. There will be different presentations, though, depending on the location of injury to this nerve. Now, an injury to the elbow can result in something called ape hand deformity. Because of the loss of the innervation of the thenar muscles, the patient is unable to abduct the thumb, so the thumb will be unable to move the thumb away from the hand, kind of looks like an ape. Now, an injury to the elbow or even above may result in what's called the hand of benediction or Pope's blessing. Here, the patient loses the ability to flex digits 2 and 3, the index and the middle finger. So when you ask the patient to make a fist, they can flex the pinky and the ring finger, but they can't flex the index and the middle finger. So what does that look like? Well, it actually kind of looks a lot like the ulnar claw, doesn't it? Well, the difference is that the patient with an ulnar claw can't extend the pinky and the ring finger even at rest. Those fingers are chronically flexed. The hand of benediction is only apparent when you ask them to make a fist. They can't flex the index and the middle finger. When their hand is relaxed, then they can actually look almost normal, where the ulnar claw, when relaxed, always looks abnormal. Now, the other high-yield pathology associated with the median nerve is carpal tunnel syndrome. Very, very common. So this is a median nerve entrapment at the carpal tunnel enclosed by the inelastic flexor retinaculum ventrally and then the carpal bones dorsally. Now, the primary symptom is intermittent numbness of the thumb, the index, the middle finger, and half of the ring finger. Now, it occurs at night or during the times of compression, like typing on a computer. Now, at night, patients will kind of naturally flex their wrist while sleeping. Now, this can lead to permanent nerve damage, atrophy of the thin arm muscles, and weakness of the palmar abduction. So on questions, look for the location of the numbness. Remember, numbness in the thumb, index, middle, and then half of this ring finger. Moving on to the musculocutaneous nerve. So the musculocutaneous nerve is a bit easier to remember. It innervates the coracobrachialis, the biceps brachii, and the greater part of the brachialis. Now don't get the brachialis mixed up with the brachioradialis. The brachioradialis, which we've already talked about, is innervated by the radial nerve. The brachialis is innervated by the musculocutaneous nerve. So what do these muscles do? They are the major flexors of the forearm and also work to supinate the forearm. The sensation supplied by the musculocutaneous nerve is the lateral side of the forearm. Pathology to the nerve will simply impair forearm flexion and supination. You can't do your curls real well. All right, moving on to the axillary nerve. Axillary nerve will innervate the deltoid, teres minor, and the long head of the triceps brachii. Now remember that the other triceps are innervated by the radial nerve. Now the deltoid acts to abduct the shoulder, the triceps act to extend the forearm, and the teres minor acts to externally rotate the humerus. Now the highest yield injury here is with a dislocation of the shoulder or fracture of, again, we talked about this before, the surgical neck of the humerus. An injury to the nerve will result in loss of abduction of the arm, weak flexion, extension and rotation of the shoulder, and loss of sensation over the lateral shoulder. Test questions will also ask which artery runs with the axillary nerve, and it's the posterior circumflex. Now let's move on to the long thoracic nerve. The long thoracic nerve, so this innervates your serratus anterior. Remember the mnemonic we talked about before was SALT, S-A-L-T. Now the serratus anterior acts to hold the scapula to the thoracic cage. The serratus anterior is also used for abduction beyond the horizontal position. The long thoracic nerve does not supply any sensory info. Now, without a functioning serratus anterior, the scapula is going to protrude out. We call this a winged scapula. The long thoracic nerve can be damaged to a blow to the neck or shoulder or has been known to happen after a mastectomy as well. All right, guys, so that was a bunch of info. Let's review it again in a game show. Don't look at your notes. I'm going to give you some muscles and you name the nerve that innervates them. So first one here, supinator, brachioradialis, triceps. The answer is radial nerve. Next, flexor digitorum profundus, third and fourth lumbricals, flexor carpi ulnaris. Answer, ulnar nerve. Next, pronator teres, palmaris longus, first and second lumbricals. Answer is median nerve. Next, coracobrachialis, brachialis, biceps. That's going to be the musculocutaneous. Next, we have long head of the triceps, teres minor, deltoid. The answer is axillary nerve. Now, one last topic I want to mention that we sometimes see on tests is shoulder abduction and the muscles involved in the various phases of shoulder abduction. So there are 4 muscles responsible for shoulder abduction, but they don't all act at the same time. The supraspinatus will initiate the first 15 degrees of abduction along the vertical plane. So when the arms are at the sides of the body, to initiate that abduction, the supraspinatus is going to act first. Now the deltoid is going to function from about 15 to 90 degrees. And then finally, the trapezius and the serratus anterior act together to abduct from 90 degrees to 180 degrees. So let's take it one more step and review the nerves involved. So the suprascapular nerve innervates the supraspinatus, the axillary nerve innervates the deltoid, the accessory nerve innervates the trapezius. And then finally, that long thoracic nerve is going to innervate the serratus anterior. So if a patient has shoulder abduction problems, look precisely where they have the weakness. Is it with initiating, before 90 degrees, or after 90 degrees? All right, that's it for the video part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. First question, what nerve is damaged when a patient presents with the following symptom? And this is of the upper extremity. So first we have unable to fully extend at DIP and PIP, fourth and fifth fingers. Remember, that's going to be the ulnar nerve, and that ends up giving you that ulnar claw. Next, unable to flex index and middle finger. Remember, that's the median nerve, and that's that hand of benediction. Next, we have wrist drop. That's going to be radial nerve. Scapular winging. That's going to be the long thoracic nerve. Loss of sensation over fingers 1 through 4. That's going to be the median nerve. Next, we have cannot abduct or adduct fingers. That's going to be the ulnar nerve. Loss of shoulder abduction. That's the axillary nerve, as well as the suprascapular accessory and long thoracic. Next, we have loss of elbow flexion and forearm supination. That's going to be musculocutaneous. And then finally here, loss of wrist extension. That's going to be radial nerve. Next, what nerve is most at risk of injury with the following types of injury? First, we have fracture of the shaft of the humerus. Remember we talked about this, that's that radial nerve again. Fracture of the surgical neck of the humerus. That's going to be the axillary nerve. Anterior shoulder dislocation, axillary nerve again. Then injury to the carpal tunnel, that's going to be median nerve. Next, a patient falls off a motorcycle and lands on his right shoulder. On physical exam, you notice his shoulder has an abnormal configuration. X-ray indicates an anterior dislocation of his shoulder. What artery and nerve is at most risk of being damaged? So this is the axillary nerve, cover that. And do you remember it? It's going to be the posterior circumflex artery because they run together. All right, guys, that brings us to the end of this video. I hope you learned something. I'll see you next time.
Good evening. Dr. Acula here once again for tonight's Ask Dr. Acula. Tonight's question comes to us from Paul in Los Angeles. Paul writes, "Hey there, Dr. Acula, your show is great and I dig your cape." Why, thank you, Paul. What condition is caused by lesions of the long thoracic nerve? The long thoracic nerve innervates the serratus anterior, which is located on the side of the thorax and acts to pull the scapula forward. Trauma to this nerve, in turn, causes the shoulder blade to protrude from a person's back. This condition is known as winged scapula. Great question, Paul, and you guys keep those questions coming. Now, I've got to fly.
Let's go over the warm-up. First question, which type of hypersensitivity is responsible for each of the following clinical scenarios? Post-streptococcal glomerulonephritis is a type 3 hypersensitivity. Rheumatic fever is type 2 hypersensitivity. Polyarteritis nodosa is type 3. Serum sickness is type 3. And then contact dermatitis is a classic type 4 hypersensitivity. Last question, what are the differences between essential tremor, resting tremor, and intention tremor? So essential tremor is a tremor that occurs both with movement and at rest. There's often a family history of tremor in these patients. Intention tremor is associated with cerebellar damage, and this tremor appears only with voluntary movements. So when you intend to move, the tremor kicks in, so it's called an intention tremor. And then resting tremor is associated with Parkinson's disease, and this tremor occurs at rest, but then it disappears with voluntary movement. Now let's move on to the lecture.
Hello everyone and welcome to our step 1 video on the lower extremity. To all of you that nervously bounce your legs up and down while studying, please stop. You're freaking the rest of us out. Thanks bunches. Okay guys, so this one is pretty anatomy heavy again. We're talking about the lower extremity. And in that last video, we hit the upper extremity, so now we're moving to the lowers. Now we're looking at the lower extremity nerves and then the muscles that they innervate, and also pay special attention to the injuries and the sensory and motor deficits. All right, so let's talk about the femoral nerve first. So it's going to innervate the psoas and the iliacus. Now together they make the iliopsoas. You're going to hear that probably more often. Now it also innervates the pectineus and the sartorius. So those are your three hip flexors. So the iliopsoas, the pectineus, and the sartorius. Now the femoral nerve also innervates the knee extensors. So these would be the quadricep muscles. So that includes the vastus lateralis, intermedius, and medialis, and then also the rectus femoris. So that's what your femoral nerve is going to innervate. So let's quickly review the anatomy again. So first is the femoral nerve. Here you see the psoas muscle. Here is the iliacus, and then together they both make the iliopsoas. Here is the pectineus and the sartorius, that really long muscle going across your leg. And then the vastus lateralis, the rectus femoris, and then the vastus medialis. All right, so that's what your femoral nerve is going to innervate overall. So one way to remember this is that you need the femoral to kick a football. So femoral football, F and F, remember that. So to kick that ball, you have to flex the hip, you have to extend the knee. So what about sensation? Well, the femoral nerve is responsible for cutaneous sensation along the anterior thigh and the medial lower leg. So how does one injure the femoral nerve? Well, the femoral nerve has the potential of being injured after a pelvic fracture. So after injury to the femoral nerve, patients will have difficulty with that thigh flexion and leg extension, so they can't kick a ball. And then patients would also have that decreased sensation on the anterior thigh and the medial leg. So likely after a pelvic fracture, you won't be able to test strength very well because they'll have significant pain and weakness due to that fracture. But you might get a better idea if the femoral nerve is damaged by testing the sensation of that anterior thigh or again that medial lower leg. So now let's move on to the obturator nerve. So what about that one? So your obturator nerve innervates the adductors of your hip. So this includes your adductor magnus, longus, and brevis. And then your gracilis is the exception. It's a knee flexor. So it's going to innervate one knee flexor as well, but also I want you really to connect obturator nerve with the thigh adductors. So one way to work out the hip adductors is to get on that horrible machine at the gym where you kind of spread your legs apart and then you show off to everyone you're growing and then you kind of squeeze them together. So one memory tool is that working out your obturator is awkward. So obturator and awkward, remember those two things. So what about sensation? Well, the obturator is going to provide sensation to the medial thigh. That's kind of where that machine is touching you as well. It's another way to remember that. So how do you injure the obturator nerve? Well, an anterior hip dislocation can lead to this, and the patient would be left with decreased thigh adduction, decreased sensation on the medial thigh as well. So remember, anterior hip dislocation. Let's move on to the superior gluteal nerve. So the superior gluteal nerve, it's going to innervate the tensor fascia lata, the gluteus medius, and the gluteus minimus. And these are involved with hip abduction and medial rotation of the thigh. So hip abduction, medial rotation of the thigh, remember that. Now the superior gluteal nerve does not supply any sensation to the leg, so that's easy. And this nerve tends to be injured with posterior dislocation of the hip. And it's also famously injured in polio as well. An injury to that superior gluteal nerve gives rise to a characteristic type of gait called that Trendelenburg gait. Now, normally, whenever a person takes a step, the gluteus medius contracts in order to keep the pelvis from tilting downward towards the leg that was raised. If you lose the ability to contract that muscle, then you will see that tilt of the pelvis to the contralateral side. So the contralateral hip drops when standing on the leg ipsilateral to the side of the lesion. Now, the Trendelenburg gait is actually a compensation gait where the patient has to kind of lean towards the affected side to attempt to keep the pelvis level. All right, moving on to the inferior gluteal nerve. So this is going to innervate the gluteus maximus, and that muscle is involved with hip extension and lateral rotation of the thigh. Now, injury to this nerve is actually pretty rare. It could happen with a posterior hip dislocation. Sometimes it can occur with a posterior approach to the hip during hip replacement surgery as well. Now, with this injury, a patient would have a hard time getting up from a seated position or climbing stairs or really even just walking. Next is the sciatic nerve. The sciatic nerve begins in the lower back and it runs through the buttock and down the leg. Now, at some point between the pelvis and the popliteal fossa, it's going to branch into the tibial nerve, which travels down the posterior compartment of the leg, and it branches into the common fibular nerve, which travels down the anterior and lateral compartment of the leg. Now, the tibial branch innervates the biceps femoris, your semitendinosus muscle, and the semimembranosus muscle. And it's also your adductor magnus as well. Now, these are involved with hip extension and knee flexion. Hip extension, knee flexion. And those first three are essentially your hamstring muscles. Also note that the adductor magnus muscle is innervated by both the obturator nerve and that tibial nerve, also known as the tibial branch of the sciatic nerve. So the sciatic is going to supply sensation to the posterior aspect of the thigh and the gluteal regions, as well as the entire lower leg, except for the medial side. Now, injury or compression of the sciatic nerve is actually very, very common. Intervertebral disc herniation, spinal stenosis, spondylolisthesis can all cause compression of the sciatic nerve, which leads to pain in the lower back, the buttock region, and then pain is going to travel down the leg. Now, remember, the famous straight leg test, where you're having people lay down, lift your leg up straight, is often very helpful in the diagnosis with this one. All right, so now let's move on to the tibial nerve. We're actually moving further down the leg. So the tibial nerve innervates your calf muscles, your gastrocnemius, the soleus, and the plantaris. So those are involved with plantar flexion. So your popliteus is a muscle that unlocks the knee when your knee is locked in extension. The flexor hallucis longus and the flexor digitorum longus are involved in toe flexion. Your tibialis posterior is involved with inversion of the foot. So lots of different actions there. Now, the tibial nerve will contribute to the formation of the sural nerve. The tibial nerve will then branch into the foot into the medial plantar nerve and the lateral plantar nerve. Sensation of the tibial nerve will include the sole of the foot, important one there. Now, the sural nerve, one of the branches there, will provide sensation to the back of the calf. So when might you injure the tibial nerve? Well, with knee trauma, you might injure the tibial nerve. It's running right behind the knee, so it would be susceptible to an injury there. Look for loss of sensation again on the sole of the foot. Let's move on to the common fibular nerve. The common fibular nerve is also known as the common peroneal nerve. You might actually hear peroneal a little bit more often. So the common fibular nerve innervates the peroneus longus, the peroneus brevis, and the short head of the biceps femoris muscle. So this nerve is going to give rise to the lateral sural cutaneous nerve and the superficial fibular nerve. Sensation is the lateral lower leg and the top of the foot this time. Now, damage to this nerve typically results in a foot drop. So you lose dorsiflexion. The patients can kind of drag their foot along when they walk. Patients can get what's called a peroneal neuropathy, where patients will develop problems from chronic compression, like prolonged bed rest, or even just from habitual leg crossing. This can happen as well. It's also commonly injured with a fracture of the neck of the fibula. Next, we have the deep peroneal nerve, also referred to as the deep fibular nerve. So the deep peroneal nerve innervates the peroneus tertius, which is involved with foot eversion. It also innervates the tibialis anterior, the extensor hallucis longus, and the extensor digitorum longus. So all three of those are going to be involved with dorsiflexion again of the foot. Now, injury to this nerve can occur with a traumatic injury to the lateral knee, and again will result in a foot drop. Now, just like, again, like the common peroneal or the common fibular nerve with that foot drop. So those two you can kind of put together. Okay, so I know this material is hard to memorize. Let's review it again with a Lewis Notes.
All right, everybody, we're going to go through our lower extremity nerves now. First, we're going to go through our green section here. That's going to be the types of injury that's going to cause injury to these nerves. And then the blues are going to be the type of manifestations you're going to see with that nerve being injured. So first one here, we have anterior hip dislocation. That's going to go with your obturator nerve there. Disc herniation, that one's easy. That one goes with sciatic. I always think of an old guy going, my sciatica, and that always makes me think of back pain. Pelvic fracture is going to be over here with the femoral. And remember, write these along with me. It'll help you remember that stuff. Posterior hip dislocations. We have two of these in a row, and luckily they kind of go into the same place. The way I remember that is that gluteals in the butt and posterior of the hip is kind of the butt area. So posterior gluteal, that's kind of how I remember that. Knee injury, just a general knee injury, that's how I remember the tibial. But then a lateral knee injury is going to go over here with the deep peroneal. So that goes there. So now let's talk about the type of manifestations we're going to see here. So first we have a sensation of the lower leg. Now this excludes the medial side. I didn't put that on there because I ran out of room. But that's going to be with your sciatic nerve here. Foot drop, when you have a foot drop, you're going to be harming your deep perineal nerve here. Trendelenburg gait, that's going to be that funny gait where you're dropping your contralateral hip. That's going to be your superior gluteal there. Plantar flexion is going to be over here with your tibial nerve. Hip extension, this one's a little bit nonspecific, but when I think of hip extension, I think of my inferior gluteal. There is some of that with superior gluteal as well. Thigh adduction, so that's the adduction, that's going to be over here with your obturator nerve. We're going to pull that there. Thigh flexion is going to be right above that, so femoral and obturator work side by side. Sensation of the anterior thigh. So sensation of the anterior thigh is going to be over here with your femoral. So I think when you're doing your thigh flexion, you're also looking at the front of your leg. So that's anterior thigh where you're going to see sensation. Then sensation of the medial thigh on the inside kind of goes along with that adduction as well. That's how I remember that. All right, so that is a little bit complicated, but write these yourself and I think you'll get them down.
All right, so now we're moving on. Let's talk about the lower extremity dermatomes, and this is worth knowing again. So first you have T10 dermatome. That's going to start about your belly button. And now underneath that you have the T11 and T12. And then you really just label them going down. L1, L2, L3, L4, L5, and then your S1 on your fifth toe, and then S2, S3 innervate your genitalia as well. Now on the posterior aspect, starting at your rectum, the rectum is going to start at S5, and then coming off of that you have S4, S3, S2, S1 going down the back of your leg. And then you have the L5, L4, L3, L2, L1, and then to T12 again. So be aware of those. Those are a bit difficult sometimes, but again, you might just need to stare at those a bit to memorize them. All right, so now let's move on to the arteries of the leg. Again, more anatomy. So starting at the top, you have the aorta, and then your aorta is going to bifurcate, and you have the common iliac artery. And then your common iliac bifurcates into the internal iliac and the external iliac. The external iliac gives rise to the deep femoral or femoral, and then the femoral artery. And then the femoral artery goes behind the knee and gives rise to the popliteal artery and the posterior tibial artery, which is the artery of the posterior compartment. And then on the anterior aspect of the leg, you have the anterior tibial artery, which is the artery of the anterior compartment. Now coming off the anterior tibial artery is the dorsalis pedis. So this is the artery that you might try to palpate to determine if lower extremity pulses are strong. And then on the back of the leg, the posterior tibial can give rise to the fibular artery, also known as the perineal artery. Again, this is just a memorization, but overall, not that tough. All right, guys, so that's it for the video part. It's time for the end of session quiz. Try to answer those questions first, and then we'll go through them together. First question, which nerve would most likely be damaged with the following injuries? So first we have a pelvic fracture. Think about your femoral nerve. Next we have the anterior hip dislocation. Think of obturator nerve. Next we have posterior hip dislocation. That's going to be the superior and inferior gluteal nerves. Next we have vertebral disc herniation. That's going to be sciatic nerve. Knee injury, think globally as a tibial nerve. Habitual crossing of the legs, common fibular or common perineal nerve. Next, which nerve is responsible for the following functions? So first we have hip flexion and knee extension. So remember that's your femoral, it's kicking a football. Sensation to the medial thigh. Think of obturator and that terrible machine you got to use. Helps to prevent Trendelenburg gait. Think of the superior gluteal nerve. Sensation of lower leg, except for the medial aspect, think of sciatic. Sensation of the sole of the foot, think of the tibial. Dorsiflexion of the foot, think of the common and the deep perineal / fibular nerve. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Welcome to the warm-up review. Just one question, but it's a long one. Name 8 different indirect cholinergic agonists and state the use for each. So indirect cholinergic agonists work by inhibiting the enzyme acetylcholinesterase, thereby allowing acetylcholine to stick around longer. So they increase cholinergic neurotransmission, but they do it indirectly. The drugs include neostigmine, which is the prototype indirect agonist, It's used for neurogenic ileus. It's a post-op reversal agent for neuromuscular junction blockade, and it's sometimes used for myasthenia gravis as well. There's pyridostigmine, which gets rid of myasthenia gravis. There's edrophonium, is a drug that's occasionally used to diagnose myasthenia gravis. There's physostigmine, which is used to treat atropine overdose. And there's ecothiopate, which was a drug that used to be used to treat glaucoma. Then there are also 3 cholinesterase inhibitors used to treat Alzheimer's disease. These are donepezil, galantamine, and rivastigmine. All right, now let's get started with the lecture.
Hello everyone and welcome to our video on sensation. Talking about sensation always puts me in a certain mood. You feel me? If you do, I hope you're using your Meissner corpuscles. Those are the rapid adapting ones, just like me. Not sure what that means, but it sounds good. Or maybe you prefer the Pacinian corpuscles. Don't call them Pacinian, that's improper pronunciation. Ooh yeah. Those sense vibrations and pressure just like me. And why not? I have those complex sensory structures, just like everyone else. Okay, I think we can stop doing this now. I'm starting to kind of weird myself out. Getting kind of creepy.
All right, on to the lecture. So today we're talking about sensory stuff, and we're going to start off talking about the sensory corpuscles, or the nerve receptors that we're going to find in the skin, and in general about neurosensation and the way we receive input from our external environment. Now, there are 5 sensory receptors that we need to talk about right now. You have your Merkel nerve endings, the Meissner corpuscles, the Ruffini endings, the Pacinian corpuscles, and the free nerve endings. Lots of weird names here, so that was what makes them fun. So first, let's hit the Merkel nerve endings. So the Merkel nerve endings are myelinated, and they're classified as slowly adapting receptors. You got to remember this stuff because each one of these can be a little different. And they transmit information regarding static pressure, sometimes texture, and even position sense. Now, these have a wide distribution. They're found along with Meissner corpuscles in the superficial skin layers, especially in the fingertips. And you'll find that we have a lot of different receptors in the fingertips. But they're also found, this is important, in hairy skin and actually in hair follicles. And then under the microscope, the Merkel cells actually look a bit like melanocytes. So you might make that connection there too. Now next are the Meissner corpuscles. Now these are again myelinated, and they're responsible for sensitivity to very light touch and are considered rapidly adaptive receptors. Now these are concentrated in areas especially sensitive to light touch, like the fingertips, just beneath the epidermis. So they're mostly superficial nerve endings here, and these are going to sense a lot of dynamic changes. Now, next are the Ruffini endings. Now, these are slowly adapting receptors, and they're found in deeper tissue, so they're deeper into the subcutaneous tissue. Now, they are spindle-shaped when you look underneath the microscope, and they're sensitive to skin stretching, and they're going to help in position sense, especially in control of finger position and movement. So these receptors are able to sense joint movement changes and sustained pressure on the skin. So they serve actually a pretty similar function to the Merkel nerve endings, but they're found deeper in the skin in the body. Now, the final one, the final one is the Pacinian corpuscles. Sometimes these are referred to as the lamellar corpuscles, and these are again myelinated. And these, like the Ruffini endings, are found in the deeper tissues again. They're rapidly adapting and are great at detecting vibration and dynamic pressure. Now, if you look at these underneath the microscope, then you're going to see kind of an onion-like pattern. And then our final one are the free nerve endings. They don't get a funny name. These are unspecialized nerve endings. They're primarily going to detect pain and temperature. Now, they have no complex sensory structures like the previous receptors that we just talked about, but they are still the most common type of nerve ending. They're kind of the generic version. Now, they're found in the epidermis and will vary in rate of adaptation depending on the type of sensory nerve fiber attached to them. So there are 2 fibers that I want you to remember. Now, the first one is the A delta fiber. These are myelinated, and they can send very fast, very quick signals of pain back to the brain. So very prickly, very sharp pain, and they're also useful in detecting cold temperatures. And then the second nerve fiber is the C-type nerve fiber. These are unmyelinated, our first unmyelinated one here, and they transmit information more slowly. So they're found in the autonomic nervous system as postganglionic fibers, but they also carry sensory information as well. So the type of pain that you would feel from these type of fibers would be sort of a burning or a dull type of pain, sometimes referred to as neuropathic type pain. Now this is mainly because they transmit that information more slowly. And like the A delta fiber, they can sense a type of temperature, but they're much more often going to be sensing a warmth more so than a cold. Now, We've been talking about this. What does it mean slowly adapting versus rapidly adapting? What does that indicate here? So let's clarify that a bit here. Now, the slowly adapting sensor is going to send a continuous electrical signal throughout a continuous stimulus. But the rapidly adapting signal is going to send an electrical signal only at the beginning and the end of a continuous stimulus. So if someone touches your arm, initially you're going to feel that rapidly adapting receptor going off. It's going to sense the beginning of that stimulus. Now, if you keep the finger there on the arm, it's not going to sense it at that point with the rapidly adapting. The reason you'll perceive that finger is still there is because these slowly adapting receptors are working. And then when that finger is removed, you're going to again perceive that removal, that change in sensation with the rapidly adapting receptor. So rapidly adapting senses the beginning and the end, the slowly adapting senses the sensation the entire time. So those are really the different receptors you need to remember here. Okay, so now let's go through some of these high yield stuff again in a Lewis Notes. Hello everyone, welcome to another Lewis Notes. We're going through these receptors again. We're just going to do this a second time. Repetition is the key to learning this type of stuff. And this is a little bit tricky because you got a couple of sets of slows, a couple of sets of rapids, and then depending on their location, superficial versus deep and all that great stuff and what they actually sense. So let's go through this again. Fill this out in the study guide if you haven't already done so. And this will just be another way of getting through this. So let's go through the Merkel nerve ending first. Adaptation is going to be very slow on this one. You're going to get a lot of static pressure. Remember, when it's slow, you're only going to feel it throughout the entire time period rather than in the beginning and the ending of the stimulation. And remember, this is going to be superficial. So superficial is, probably places like fingertips, but in other places. The other thing to remember about location with Merkel's, think of hair follicles and hairy areas. And then the last thing to remember is that these look a little bit like melanocytes. So if you can remember melanocyte, then that's another pathological thing that you might see if you get a pathology slide. Next, let's move on to Meissner corpuscles. These are going to be rapid, so that's how they're going to be different than the Merkel in regards to that, because they're both going to end up being superficial. This is going to be light touch, very fine touch. Again, you're going to see a lot of this in the fingertips. This is going to be superficial again, so superficial is the key to remembering those two and how they're different from Ruffini and Pacinian. So Ruffini is the next one. This is going to be another slow one, and this is going to be a lot of pressure. Position is another one, so position sense is another thing that we're going to see with these. And then these are going to be deep, so that's how it's going to be different in relation to our Merkel type receptors. So deep, and then the other thing to remember here is these are kind of spindle shaped. So if you can remember spindle for these, that's another thing to remember. Pacinian, these are going to be rapid again. So a little bit similar to the Meissner here. You're going to get a lot of vibration sense here. What's different about these is that it's going to be deep again. And remember here, you're going to be feeling a much deeper sensation, maybe more position sense as well, dynamic pressures. And then the other thing to remember here is that you're going to see onion shaped. So onion shaped is another thing to remember there. And then we move on to our free nerve endings. So remember, our two free nerve endings are the A delta and the C fiber. The A delta, remember, is going to be very rapid there, and then the C fiber is going to be very slow. This is going to be sharp pain, and this is going to be very dull pain. And then this is going to be cold, and this is going to be warm. So that's, you've got to remember there. So A delta is sharp and cold. The C fiber is going to be dull and warm. Think of kind of a burning sensation with that C fiber. And these are pretty much everywhere. Think superficial, probably maybe primarily, but really it's just kind of everywhere when you think about how many nerve endings we just kind of have all throughout our body trying to sense pain, because we try to avoid painful stimuli. All right, so if you can kind of remember just these very, very high yield stuff, I think you do pretty well with our sensory corpuscles. All right, so now let's move on to the anatomy of a peripheral nerve. This is really quick here. So a peripheral nerve has several layers. It has an endoneurium, it has a perineurium, and an epineurium. Now the epineurium, as the name implies, is on the outside of the nerve. It is the very dense connective tissue that contains things like blood vessels. And overall, it's going to be responsible for just keeping the whole nerve bundle together. Now the perineurium is what surrounds a fascicle of nerve fibers. So you can remember the word peri means around. And then the endoneurium is again a type of connective tissue that surrounds each individual nerve fiber. And this is again, as the name implies, that innermost type of connective tissue. So not too hard to remember those three structures there. So let's move on to our next subject. let's talk about Schwann cells. So what myelinates your peripheral nerve cells? It's going to be your Schwann cells. Now the Schwann cells are the principal glia of the peripheral nervous system. Now these cells support the neurons. They're the big helpers. Now they help with conduction of impulses along axons. They help with nerve regeneration, and they can even help present antigens to T lymphocytes. Now one Schwann cell will myelinate just one peripheral axon. Now the myelin is going to be very important. It's going to assist in the conduction of an action potential down an axon through a process called that saltatory conduction. So now let's move on to some pathology. And the first one we're going to talk about is Guillain-Barré syndrome. So this is an autoimmune inflammatory demyelination syndrome of the peripheral nerves at the Schwann cells. Now, so you have autoimmunity actually against the Schwann cells themselves. Now, it is thought that this is due to a molecular mimicry problem. Now, there are a few infections potentially associated with the development of Guillain-Barré, and the one that's probably most commonly realized is Campylobacter jejuni. About 20% of patients with Guillain-Barré will have had some type of diarrheal illness within the last month. However, still, you're looking at 80% here. Most of the time, the cause is idiopathic. But if there is some type of infection in the last month, usually it's going to be gastrointestinal, maybe a respiratory tract infection. Stress also seems to be associated with this as well. So how does Guillain-Barré present? Well, patients lose function of the peripheral nerve axons. Therefore, they get an ascending muscle weakness. Now, the thing that's really interesting and unique about Guillain-Barré is that you usually don't have a lot of sensory problems. You can have some pain, some other issues going on, but it's mostly a muscle problem. So the disease is preferentially affecting the peripheral muscle Schwann cells. And this ascending weakness starts in the legs and then moves to the hands and goes up the trunk and then potentially can involve the face as well. In about 50% of cases, there's facial weakness. About 10 to 30% of patients will experience respiratory muscle weakness that even requires ventilatory support. So this is going to progress over the matter of days, maybe over weeks if it's very slow, but most of the time over a span of days you're going to see this progressive weakness. And then hopefully there's going to be a plateau if they've survived, and then a recovery phase, and that takes weeks to months. Now, one high-yield trick is that if you see bilateral facial muscle paralysis or weakness on your test, think about two things. The first one is Guillain-Barré syndrome. The second one that you maybe won't think about is Lyme disease associated with Bell's palsy. So bilateral Bell's palsy, think about Lyme disease and think about Guillain-Barré. Now, the diagnosis is usually made by nerve conduction studies. So you're going to do those nerve conductions. You're going to see decreased conduction through those nerves. Also, there's going to be an elevation of CSF protein, but you're going to have a normal cell count. So how do you treat this? Well, most of the time supportive care is all that's needed. You're going to monitor the vital signs. You're going to provide respiratory support as needed. You're going to provide nutritional support as needed. Sometimes they have trouble swallowing in this situation. If you catch this early, sometimes you're going to do plasmapheresis, especially if it's very severe. Since this is an autoimmune disease, by decreasing the antibodies, you can actually affect some improvement. IV immunoglobulins can also be helpful as well. All right, so let's go ahead and briefly mention just the very, very high-yield other types of demyelinating diseases. We won't go into as much detail on these. So first we have progressive multifocal leukoencephalopathy. So leuko meaning white matter. So in this disease, you have demyelination of the central nervous system due to destruction of oligodendrocytes. So where Guillain-Barré was the Schwann cells, now we're dealing with oligodendrocytes. Now, one thing to remember, oligodendrocytes in Schwann cells are basically the same cell, but Schwann cells are in the peripheral nervous system, the oligodendrocytes are in the CNS. And this is associated with the JC virus, which is a classic disease in AIDS patients. The next one is called acute disseminated post-infectious encephalomyelitis. So here you have inflammation, demyelination, and this is just after a viral infection. Most commonly we associate this with things like chickenpox or measles, possibly after certain vaccinations as well. The next one is called metachromatic leukodystrophy. Again, dystrophic white matter. So this is an autosomal recessive lysosomal storage disease, and this is due to a deficiency of aryl sulfatase A. And then because of that, there's a sulfatide buildup and then destruction of the myelin. Then the next one is Charcot-Marie tooth disease. So this is a hereditary motor and sensory neuropathy. So it's characterized as a progressive loss of muscle tissue and touch sensation across various parts of the body. It's caused by mutations that cause defects in neuronal proteins. So there can be problems with neurons. There can be problems with myelin sheaths as well. I actually have a patient that couldn't feel his feet very well due to this disease, which then led to chronic trauma, and then eventually had to have one of his feet amputated. All right, guys, that brings us to the end of the lecture part. It's time for the end of session quiz. Let's go through those answers together. First question here, what sensory receptor communicates with the following information? So first we have prickling pain, so fast myelinated type pain. That's going to be your A delta fibers. Next we have burning or dull pain, and maybe an itch, a slow unmyelinated, that's going to be your C fibers. Next we have vibration and pressure rapid adapting, that's going to be your Pacinian corpuscles. Dynamic, changing, a light discriminatory touch, maybe that's going to be your Meissner corpuscles. Got a lot of those in your fingertips. Next we have static, unchanging, light touch. Superficial though, think of Merkel nerve endings there. Next question, what CSF changes are present in Guillain-Barré syndrome? So we went through this very briefly. So you're going to have a normal cell count, but you could possibly have an increase in the protein in your CSF. The next question, what are the classic manifestations of Guillain-Barré syndrome? So remember, it's muscle weakness. So what type of muscle weakness? It's going to be an ascending, so it starts in the lower extremities and it's going to ascend. It's going to be symmetric. There can also be facial paralysis. There can be respiratory distress as well. And it can be preceded by maybe a diarrheal illness. Try to remember Campylobacter jejuni. That's going to be the most common association there. All right, guys, that brings us to the end of Neuro 22. I hope you learned something. I'll see you next time.
Welcome back. Now, you may have noticed before the commercial break that we had a minor setback, but everything is good now, right? Great. Let's get back to the questions. Mary, what is your question?
Hi, Dr. Frankenstein. Love your show.
Why, thank you, Mary.
My question is, what is the characteristic presentation of Guillain-Barré syndrome?
That's a great question, Mary. Guillain-Barré syndrome presents as ascending muscle weakness, which begins in the feet and moves up the body.
Sensory.
What was that?
Sensory.
One more time?
Sensory.
Oh, yes. Forgive me. Ascending muscle weakness without sensory loss. Thank you, Monster. It's okay. We're okay. And the characteristic CSF findings in patients with Guillain-Barré syndrome is elevated protein with normal cell count. You're right, Monster. We are out of time. That's the end of our show. Please remember to keep those questions coming. Until next time.
It's time for another warm-up review. Let's get going. Which cytokine, more than any other, should be known as the macrophage activating cytokine? That's going to be interferon gamma. Next, which complement is responsible for neutrophil chemotaxis? That's going to be complement C5a. Next, which pupillary sign suggests a diagnosis of syphilis? Remember, that's going to be the Argyll-Robertson pupil. This is the pupil that is not reactive to light, but constricts with accommodation. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
In this video, we're going to talk about diseases that affect the eye, both intrinsic eye diseases like glaucoma and cataracts, and also the ocular manifestations of systemic diseases. We're going to start at the anterior part of the eye and then work our way back to the retina and the optic nerve. So let's start with a quick review of eye anatomy. So the white part of the eye is called the sclera, which is like the hard shell that surrounds and protects all the delicate structures within the eye. And actually, the anterior sclera is covered by an epithelial layer called the conjunctiva, which produces mucus and tears to lubricate the surface of the eye. Then the cornea is this clear dome that lets the light in. It's not actually the same color as the sclera, despite what it looks like on this drawing. Now, the colored part of the eye is the iris, and the iris has muscles that can dilate or constrict the pupil to regulate how much light comes in. And behind the iris, you have the lens, which can also change shape because it's attached to the ciliary muscles in the ciliary bodies. So the lens changes shape in order to focus your vision near or far. And what do we call that focusing process? Accommodation. Now, if you were to pop the eye out of its socket and then peel off the sclera, kind of like peeling a grape, you'd be looking at the uvea, which comes from the word uva, which is the Latin word for grape. So the uvea consists of the iris and the ciliary apparatus and the choroid, which is this vascular layer posterior to the retina. So all this light brown stuff would be considered the uvea. We're going to talk about the uveitis and problems that uveitis can cause in a little bit. Now, behind the lens, you have this big blob of jelly-like substance, which is called the vitreous humor, or the vitreous body.
And then at the back of the eye, you have the retina, which contains the photoreceptors that are responsible for picking up the light signal that's been focused on the retina by the cornea and by the lens. And then the retina is going to send that visual information to the optic nerve. Now, you also need to be aware of the chambers of the eye. The space anterior to the iris is called the anterior chamber. And the space posterior to the iris, but anterior to the lens, is called the posterior chamber. So the posterior chamber of the eye is not actually in the posterior part of the eye. Be aware of that.
Now let's start working our way through these various eye pathologies, starting anteriorly and working our way backwards. The most superficial part of the anterior eye is the conjunctiva. The conjunctiva is very vascular, but usually the conjunctival capillaries aren't visible. When you get allergies or an infection and you get some inflammation of the conjunctiva, those capillaries become engorged and they become visible so that the eye looks pink or red. So this child has conjunctivitis in the right eye. Now most of the time this is a viral infection. For instance, adenovirus can cause this. But if it's unilateral and it's associated with some purulent discharge, which you kind of see caked up in the eyelashes here, that's potentially bacterial conjunctivitis. And as I mentioned, allergic conjunctivitis often goes along with allergic rhinitis in the spring or the fall. Now, what's going on in the left eye? Well, this is another cause of red eye. This is a subconjunctival hemorrhage. So the conjunctiva bled a little bit, and the blood is kind of trapped between the conjunctiva and the sclera. It looks really nasty, but it's completely benign and it resolves on its own. Now, what's going on here? Well, this patient has elevated bilirubin and jaundice, maybe from hemolysis or from liver disease or obstruction of the biliary tract. You're often going to hear this called scleral icterus because it looks like the sclera is yellowed and jaundiced. But the name scleral icterus is really a misnomer because the excess bilirubin is actually deposited in the conjunctiva, not in the sclera. Next, let's discuss some pathologies of the cornea. The cornea is the clear dome that sits over the colored part of the eye and lets light pass through. Now the shape of the cornea is very important for refracting light, even before that light gets to the lens. When you do LASIK surgery, you're reshaping the surface of the cornea with a laser and changing the refractive properties of the cornea. One of the most common findings of the cornea is called arcus senilis, which is this whitish or bluish ring at the periphery of the cornea due to the accumulation of cholesterol. And as you can guess from the name arcus senilis, this is a finding seen in older individuals. You can see clouding of the cornea in mucopolysaccharidoses like Hurler syndrome, and you can get corneal abrasions or scratches on the cornea from eye trauma. And corneal abrasions are extremely painful. Once you pass through the cornea and the anterior chamber, you reach the iris, or the colored part of the eye. And we said that the iris was part of the uvea, which is that vascular layer that's sandwiched between the sclera on the outside and the retina on the inside. And when the uvea becomes inflamed or infected, that's called uveitis. Now, sometimes this is anterior uveitis or iritis, which causes pain and redness of the iris, and that redness often extends into the conjunctiva as well. There can be photophobia or light sensitivity, and you can sometimes see pus or inflammatory cells in the anterior chamber, kind of pooling up inside the cornea. Anterior uveitis is commonly seen in seronegative spondyloarthropathies like reactive arthritis or ankylosing spondylitis, and those are both associated with the HLA-B27 genotype. You can also see anterior uveitis with sarcoidosis or juvenile idiopathic arthritis and various other systemic inflammatory diseases. And then the posterior part of the uveal tract, behind the retina, in the back of the eye, is called the choroid. And if you get inflammation and infection back there, it's called posterior uveitis or chorioretinitis if it involves the adjacent retina as well. Posterior uveitis is much less common than anterior uveitis, and posterior uveitis tends to be more infectious. Things like CMV and toxoplasma and cat scratch disease caused by Bartonella Hensley. And also, psoriatic arthritis and inflammatory bowel disease can cause this, which again, those are HLA-B27 positive seronegative spondyloarthropathies. I want to spend a few minutes talking about glaucoma, which is probably the single highest yield eye disease for step 1. But in order to understand glaucoma, you really need to be familiar with the flow of aqueous humor, which is outlined in the study guide. Remember, the space anterior to the iris is the anterior chamber of the eye, and the space posterior to the iris, between the iris and the lens, is the posterior chamber. And both the anterior and posterior chambers contain a clear fluid called aqueous humor, which carries nutrients to the anterior structures of the eye. Aqueous humor is produced by the epithelium of the ciliary body, and then it flows into the posterior chamber and through the pupil in the middle of the iris into the anterior chamber. And then under normal circumstances, the aqueous humor exits the anterior chamber via the trabecular meshwork, which lies in the angle where the iris meets the sclera. But when something interrupts that normal flow, the intraocular pressure builds up and you get glaucoma. Glaucoma is a condition of elevated intraocular pressure, which eventually causes damage to the optic nerve and can result in permanent blindness. There are two different types of glaucoma. There's open-angle glaucoma, which tends to be chronic and insidious, and there's closed-angle glaucoma, or sometimes it's called angle closure glaucoma or narrow-angle glaucoma. But whatever you call it, angle closure glaucoma is usually acute and it's an emergency. Angle closure glaucoma occurs when the lens pushes forward against the iris, which plugs up the pupil and blocks the flow of aqueous humor from the posterior chamber to the anterior chamber. When the iris is pushed forward, the angle between the sclera and the iris gets narrower. That's why it's called closed angle or narrow angle glaucoma. But the main problem is thought to be the lens plugging up the pupil. In your study guide, we've listed a few important points about angle closure glaucoma. Again, acute angle closure glaucoma is an emergency. These patients typically present with abrupt onset of eye pain. They can have a frontal headache over the eyebrow and extending to the temple. They can also have nausea and vomiting, and if they look at a light source, they may see colored halos or rainbows around the light. The affected eye is usually red, teary, and angry looking. The cornea may be hazy, and the pupil is often fixed and mid-dilated. If you palpate the eyes gently, the affected eye is harder or firmer than the normal eye because of increased pressure. The goal of treatment is to break the acute attack, often by performing a laser iridotomy, which is where an ophthalmologist uses a laser to create tiny holes in the iris, to create channels that allow the aqueous humor to flow from the posterior chamber to the anterior chamber and then into the trabecular meshwork. If there's going to be a delay of more than an hour or so getting the patient to see the ophthalmologist, we use eye drops like timolol and aproclonidine to lower the intraocular pressure, and possibly we even use systemic acetazolamide or mannitol. We'll talk more about glaucoma drugs in just a moment. So that's closed-angle glaucoma. Now in open-angle glaucoma, the angle remains wide open. The lens isn't bumping up against the iris and plugging up the pupil. The problem in open-angle glaucoma is that the trabecular meshwork has lost its permeability for some reason, kind of like the oil filter in your car getting clogged up. Open-angle glaucoma is much more common than angle closure glaucoma, and it usually comes on insidiously over a number of years. It's usually bilateral. Risk factors include being over 40, being African American, family history of glaucoma, myopia, and diabetes. Diabetes can cause lots of different eye problems. In the early stages, these patients are usually asymptomatic, but they do have elevated intraocular pressure. Then later, as the glaucoma progresses and the elevated intraocular pressure does damage to the optic nerve, that results in gradual loss of peripheral vision. And ultimately, it results in permanent blindness if it's left untreated. So it's important to screen patients for glaucoma and catch it early. So how can you screen for glaucoma? Well, there are several different ways to measure the intraocular pressure, which is called tonometry. The air puff test is one you're probably familiar with, where they blow that little puff of air in your eye. You can also examine the fundus of the eye and check the optic cup to disc ratio. So when you look at the fundus with an ophthalmoscope, the big yellow circle is the optic disc, which is the head of the optic nerve. Now, the optic cup is the smaller, brighter circle in the center of the optic disc. Normally, the diameter of the optic cup is less than 50% of the diameter of the disc. Now in glaucoma, the optic cup is frequently enlarged, so it's greater than 50% of the diameter of the optic disc. So as you practice looking at patients' fundi, get in the habit of checking this cup to disc ratio. And FYI, students tell us that being able to interpret fundoscopic images like these is very high yield for step 1. Let's talk about the treatment of glaucoma. Closed-angle glaucoma is usually treated with laser surgery because that's an emergency. Open-angle glaucoma is not an emergency. You have a little time to act. So for open-angle glaucoma, we usually treat medically, trying to inhibit production of aqueous humor and improve outflow. Beta blockers and carbonic anhydrase inhibitors like acetazolamide will decrease the production of aqueous humor. The ciliary bodies have a lot of beta adrenergic receptors, and blocking those receptors helps to reduce aqueous production. And then prostaglandins, alpha agonists like aproclonidine, and cholinergic agonists like pilocarpine work by increasing outflow of aqueous humor through the trabecular meshwork. Prostaglandins and beta blocker eye drops are usually first line, and then these other classes of drugs are added as needed. And in some cases, we treat surgically with laser trabeculoplasty, which is where you use a laser to blast some tiny holes in the trabecular meshwork to improve outflow. So it's a little different than the laser iridotomy for closed-angle glaucoma. We've worked our way from the anterior surface of the eye all the way through the iris and the posterior chamber, and now we come to the lens. The main pathology of the lens I want to discuss is cataracts. A cataract is an opacification of the lens. The lens is extremely cellular, but it's supposed to be translucent to let light pass through it and focus the image on the retina. But if the lens becomes opacified, vision is impaired. Cataracts are most commonly seen with advancing age, and they're probably the most common cause of blindness. Somewhere in the ballpark of 4 million cataract surgeries are performed every year in the U.S. That's a lot of cataracts. Besides age, long-term glucocorticoid use can increase the risk of cataracts, and so can tobacco and alcohol use. And also diabetes can cause cataracts. This is a patient with a cataract, and you can see through the pupil that the lens is cloudy and opacified. Cataracts aren't always so prominent and so visible to the naked eye, but they can be. In your study guide, there are a few more details about cataracts. Cataracts are almost always bilateral, but one eye may be worse than the other. Cataracts classically present with slowly progressive, painless loss of vision. Patients typically complain that they're having difficulty driving at night, having difficulty reading road signs or reading fine print. They may have disabling glare in bright sunlight or glare from oncoming headlights when driving at night. And early on, the patient may experience some nearsightedness or second sight, or they were getting farsighted from normal aging and presbyopia, and then as cataracts develop, they start to become nearsighted and they realize they don't need their reading glasses anymore. So that might be a good historical clue. Moving to the back of the eye, let's talk about some disorders that affect the retina, starting with age-related macular degeneration. This pigmented spot is called the macula, which is the central area of the retina that has extra dense cone cells to provide fine central vision for reading and recognizing details like facial features. And if that macula degenerates as you get older, that's called age-related macular degeneration. Macular degeneration causes a loss of central vision, but the peripheral vision remains intact. There are two different forms, dry macular degeneration and wet macular degeneration. In the dry or atrophic form of macular degeneration, cellular debris called drusen accumulates between the retina and the choroid. And this causes a gradual, insidious loss of vision. The second type is wet age-related macular degeneration, which has a more rapid onset and a more rapid progression. This is caused by neovascularization or abnormal blood vessel growth in the choroid, and these fragile new vessels bleed and damage the photoreceptors. Now, one of the major risk factors for macular degeneration is smoking, so you need to counsel these patients to stop smoking. And then treatment includes supplementation with antioxidants such as beta-carotene, vitamin C, lutein, selenium, and zinc. Patients with wet age-related macular degeneration can sometimes be treated with injections of antivascular endothelial growth factor into the vitreous humor, or you can treat with laser therapy.
Now, one other pathology you can see on this image, which has nothing to do with macular degeneration whatsoever, is the presence of these fluffy white things that look a bit like clouds or maybe wisps of cotton. So these are called cotton wool spots, and they suggest the presence of focal areas of retinal ischemia, maybe from diabetes or from hypertension.
In general, diabetes is bad for the retinas. The longer you have diabetes and the more severe the diabetes is, the more likely you are to get something called diabetic retinopathy. Without getting into too much detail, with diabetic retinopathy you can see these hard exudates, which are these well-defined kind of yellowish colored spots. You can also see some flame hemorrhages, and you can see the cotton wool spots, which we saw earlier. And then in proliferative diabetic retinopathy, there's proliferation of these new blood vessels, and this is called neovascularization. And these new vessels are abnormally fragile, so they tend to rupture and bleed and ultimately form some scar tissue. So sometimes they do laser therapy to zap those new vessels so they won't keep proliferating. Another disorder of the retina is called a retinal detachment, which is where the retina literally comes detached from the back of the eye. This could be due to trauma or possibly due to diabetes again. So we've seen that diabetes causes glaucoma, cataracts, now retinopathy and retinal detachment. So it's very important for diabetics to have an annual dilated eye exam to check for any type of problems. Retinal detachment isn't painful because the retina has no pain receptors, but patients experience a sudden onset of flashing lights and floaters followed by a reduction in vision. And obviously this can result in permanent vision loss if the retina isn't surgically reattached in a timely manner. Now on fundoscopic exam, a detached retina has this sort of billowy, wrinkled, somewhat pale appearance in contrast to the smooth, normal retina. Then one last retinal pathology to mention in passing is a retinoblastoma, which is a cancer of the retina, most commonly seen in children. We're going to talk about retinoblastoma in the oncology section, but I want to mention it here since we're talking about the eye. It's pretty easy to recognize on your board exams because it's characterized by the loss of the normal red reflex. Most of the time when you shine a light into the eye, the light bounces off the retina and you see a red reflex. But if you see a white reflex of the retina, especially in a child or an infant, think about retinoblastoma. Let's discuss a couple of pathologies related to the optic nerve. First is papilledema, which is swelling of the optic disc. This is our normal fundus again, and you can see that the optic disc is nice and sharp and well defined. Now, papilledema is where the optic disc becomes sort of swollen and fuzzy and blurry. Now, papilledema isn't a disease. It's a physical exam finding that indicates increased intracranial pressure. Not increased intraocular pressure like with glaucoma, but increased intracranial pressure like from a brain tumor. And remember how the optic nerve has a central artery and vein running right through the middle of it? Well, if that central retinal artery gets occluded, that can cause ischemia of the eye. Central retinal artery occlusion will cause painless vision loss, and then the classic finding on fundoscopic exam is a pale retina with a cherry red spot in the macula. Now the retina has been cut off from its blood supply and it becomes ischemic, which makes it look pale, but in the very center of the macula, the retina is very thin, so the blood vessels in the choroid behind the macula are still visible, and that causes this cherry red spot. So what else can cause a cherry red spot on the retina? Well, you can see it with central retinal artery occlusion, Tay-Sachs disease, Niemann-Pick disease, and other lysosomal storage disorders. These will also cause a cherry red spot by different mechanisms. In lysosomal storage disorders, you have abnormal substances that accumulate in the ganglion cells of the macula and make it look red. And while we're discussing weird eye pathologies, I want to throw in a couple of brain lesions that affect the eye. The frontal eye fields are part of the frontal lobe of the brain, which controls scanning eye movements, which allow the brain to map whatever you're paying attention to. A lesion of the frontal eye field on one side will cause the eyes to deviate toward the side of the lesion. So a lesion in the right frontal eye field will cause the eyes to deviate to the right, toward the lesion. Now contrast that with a lesion to the PPRF, or the paramedian pontine reticular formation. The PPRF is a brainstem structure rather than a cortical structure that's also involved in those scanning eye movements. And a lesion of the PPRF will cause the eyes to deviate away from the side of the lesion. There's another deep brain structure called the superior colliculus that's involved in eye movements, among other things. But a superior colliculus lesion will cause paralysis of upward gaze so that the eyes tend to look downward. This is referred to as Parinaud syndrome. Now, one student suggested that you can remember this by thinking of a nerd who is superior at calculus, but he's socially awkward and he's always looking at his feet. So he's superior at calculus, that reminds you of the superior colliculus, and he's looking at his feet, so his eyes tend to look downward. You can even change Parinaud syndrome to Paranerd syndrome if you like. So now it's time for the end of session quiz. So I want you to pause the video and answer the questions, then we'll go through them together. First question, what initial type of vision loss is commonly seen in patients with open-angle glaucoma? Permanent peripheral vision loss, which can eventually progress to central vision loss. So if you see a visual field with peripheral vision loss but preserved central vision, like tunnel vision, think about glaucoma. Next, what drug classes are used in the treatment of glaucoma? Prostaglandins and beta blockers are first line. We also use alpha agonists, carbonic anhydrase inhibitors like acetazolamide, and cholinergic drugs like pilocarpine. And in acute angle closure glaucoma, we use osmotic diuretics like mannitol to lower that intraocular pressure rapidly. Last question, what's the treatment for dry, age-related macular degeneration? We talked about smoking cessation and then daily supplementation with antioxidant vitamins. That's it for now. I'll see you next time.
It's time for another warm-up. Let's get going. First question here, which spinal tracts convey the following information? So first we have pain and temperature sensation. That's going to be the lateral spinal thalamic tract. Important for postural adjustments and head movements. That's going to be the vestibulospinal tract. Then we have proprioceptive information to the cerebellum. That's going to be the dorsal and ventral spinocerebellar tracts. Next, what molecules are expressed on the surface of antigen-presenting dendritic cells? So we have MHC1, MHC2, a B7 co-stimulatory protein, so CD80 or CD86, and then you have CD40, which is a co-stimulatory protein as well. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
Good kitty. You're a pretty little kitty. Yes, you are. Oh, we're ready to start taping? In this video, we're going to talk about the ear, including both the cochlear apparatus for hearing and the vestibular apparatus for balance and sensation of head position. This is some relatively lower yield stuff, but some of this does turn up on step 1. Let's talk about hearing first. How does your ear convert sound vibrations into a neurological signal that the brain can interpret? Let's review the functional anatomy of the ear in the normal auditory pathway. This is maybe 2 stars, but it is definitely fair game. Auditory sensation starts with the tympanic membrane, which separates the external ear canal from the middle ear. Now, the bone that butts up against the tympanic membrane in the middle ear is the malleus, and that's connected to the incus, which is connected to the stapes, which is in turn connected to the cochlea. So when a sound makes the tympanic membrane vibrate, those vibrations are transmitted to the fluid inside the cochlea by this series of 3 bones. Now, the vibration of the cochlear fluid causes movements of the auditory hair cells, which are specialized receptors that perceive this vibration. There are inner hair cells and outer hair cells, which have different functions. Let's take a short detour right here for just a second. We'll pick back up here in a moment and finish following the signal all the way up to the cortex. But first, I want to mention a couple of testable points about these hair cells. When we talked about muscles and reflexes, we said there were intrafusal muscle fibers and extrafusal muscle fibers. And you could sensitize muscle fibers with gamma motor neuron innervation. That signal comes down from the brain and tells the sensory organs within the skeletal muscle to be on alert for any input. Well, you have a similar mechanism in your ear. There are efferent fibers from your brain that go to the outer hair cells of the cochlea to influence the sensitivity of those outer hair cells. These are the olivocochlear bundles, which run from the superior olive of the brainstem to the cochlea. These bundles send cholinergic signals to the cochlea, which result in contraction of the outer hair cells, and that results in stiffening of the basilar membrane inside the cochlea, which sensitizes the inner hair cells to a particular frequency. And the reason that aminoglycoside antibiotics like gentamicin cause hearing loss is that they can potentially damage those outer hair cells. Now let's get back to the auditory pathway. When a sound vibration stimulates the hair cells in the cochlea, they generate a nerve signal. And that nerve signal travels from the cell bodies of the spiral ganglion, or the cochlear ganglion, to the cochlear nuclei in the brainstem. Then that signal decussates to the contralateral superior olivary nucleus, and then travels up the lateral lemniscus to the inferior colliculus, and then to the medial geniculate nucleus in the thalamus. Remember, M for music, M for medial geniculate nucleus. And then finally, the signal goes to the primary auditory cortex, which is located in the temporal lobe. Let's talk about hearing tests like the Weber test and the Renna test. These aren't incredibly high yield, but students have reported seeing questions in which they're asked to interpret these tests, so we've got some practice for you. The Weber test and the Renna test can help you diagnose conductive hearing loss or sensory neural hearing loss, and which side the hearing loss is on. And both of these tests work together. So first you do the Weber test. You strike the tuning fork and you place the bass firmly in the midline of the skull, either on the top of the head, maybe on the forehead. It could be anywhere in the midline, between the eyes, on the maxilla, but usually we just put it on the top of the head. Then you ask the patient, do you hear anything? The patient says yes. Then you ask, which ear do you hear it in? And normally the patient's going to say both. And if it's louder in one ear than the other, that's abnormal. Now, don't write down that Weber's test is positive or negative. That's potentially confusing. You should write down Weber midline, which is normal, or Weber lateralizes to the right or to the left. In the study guide, there's an explanation of how to interpret the Weber test. Midline is normal. Both ears are working. Conductive hearing loss lateralizes to the side of the affected ear. Sensory neural hearing loss lateralizes to the side of the good ear. So think that through. If you have conductive hearing loss, the sound is louder in that ear. Try it out. You can give yourself conductive hearing loss by plugging your ear, and then try the tuning fork, and it should be louder on that side. You can use that to help you remember that conductive hearing loss lateralizes to the affected ear. If you have sensory neural hearing loss, you won't hear anything on the affected side, so the sound lateralizes to the good ear. So when you do the Weber test, all you know is that the sound lateralizes to one side or the other. You can't tell whether it's conductive or sensory neural hearing loss yet. You have to do more testing to figure it out. And that's where the Renna test comes in. In the Renna test, you test each ear separately. So you strike the tuning fork and you place the bass on the mastoid process just behind the ear. And you ask the patient if they can hear the tone. The patient says yes. Then you tell the patient to let you know the very instant the sound disappears. Depending on how hard you struck the tuning fork, it may take a little while, 15 to 20 seconds. Don't get impatient. Then as soon as the patient tells you that the sound is gone, you move the fork to just outside the opening of the ear canal, and the U of the fork should be facing forward. Then you ask the patient, do you hear it now? So look back at your study guide. Normally, air conduction is better than bone conduction, so the patient should still be able to hear the tone faintly immediately after the fork is moved from the mastoid to the canal. And you record this as air conduction greater than bone conduction on the right. If the patient can't hear the tone after you move the fork, that's abnormal. That means that bone conduction is greater than air conduction. And you record bone conduction greater than air conduction on the right. Don't say test positive on the right or negative on the left. Again, it's too easy to misinterpret. So with conductive hearing loss, bone conduction is greater than air conduction. But you can't do much with the test by itself, because with sensorineural hearing loss, you're still going to get a normal test result. With sensorineural hearing loss, the tone should still return after you switch it, because air conduction is still better than bone conduction. The problem's not conductive. So you really need to do both the Weber test and the test. And you need to test each ear independently, because they may have slightly different findings on each side. So now let's get some practice interpreting these. We've given you complete results of the Weber test and the test on each side, and you have to figure out whether the patient has conductive loss on the left or sensorineural hearing loss on the right or whatever. So pause the video and try to figure these out. All right, here are the answers. Patient A's Weber test is midline, and that's normal. And air conduction is greater than bone conduction in both ears, so that's normal. So the diagnosis here is normal. In patient B, the test is normal on the left with air conduction greater than bone conduction. But in the right ear, bone conduction is greater than air conduction. That's a huge flag that something's going on with the right ear. This indicates conductive hearing loss in the right ear. And our Weber test confirms that. Remember, in conductive hearing loss, the Weber test lateralizes to the side of the affected ear, so everything matches up. In patient C, the test is normal on both sides. So we're done, right? Wrong. This is how you get fooled if you try to hang your hat on one test without the other. The Weber test is abnormal because it lateralized to the left. So maybe that means there's a conductive hearing loss on the left, because with conductive loss, the Weber test lateralizes to the side of the affected ear. But no, the test is normal, so you can't have conductive hearing loss. So if the Weber test lateralized to the left, that must mean that there's sensorineural hearing loss on the right side, because in sensorineural hearing loss, the Weber test lateralizes to the side opposite the affected ear. So you see how important it is to do both tests. And in patient D, bone conduction is greater than air conduction in both ears, but the Weber test is normal. So in this case, you have bilateral conductive hearing loss. So that's how you interpret those.
Another type of hearing testing is audiometry, where they put the headphones on you and play the electronic beeping sounds. And audiograms are tested on both USMLE and COMLEX, so you definitely need to know how to interpret these. An audiogram plots the lowest volume at which the patient can hear each of these different frequencies. And with normal hearing, both ears are about the same, and the sound is heard pretty close to 0 decibels. But if the graph for one or both ears dips way down, that tells you there's some hearing loss. Now, as you get older, it's pretty common to have some high-frequency hearing loss, as you see here. And you can also test bone conduction using a device that vibrates the bone. So on your exam, they might show you an audiogram in which the air conduction is abnormal, but bone conduction is normal, and ask you to diagnose conductive hearing loss.
Next, let's talk about some inflammatory diseases of the ear, starting with otitis externa. Otitis externa is inflammation or infection of the ear canal. One of the hallmarks of this disease is that when you pull on the pinna, it causes ear pain. Even putting the otoscope into the ear can be very painful for the patient. It's most commonly caused by Pseudomonas, and then the second most common organism is Staph aureus. We typically call this swimmer's ear because it's associated with wetness in the ear canal following swimming. And the treatment is irrigation plus topical antibiotics, ear drops. Systemic antibiotic therapy is not necessary. This is a superficial infection just within the ear canal. Next is otitis media. Now, this is an infection of the middle ear space, which can be bacterial or viral. Both are really common. You diagnose acute otitis media by inspecting the tympanic membrane with an otoscope. The tympanic membrane may be bulging. You usually see fluid in the middle ear, so a middle ear effusion, which could be serous or it could be pus. Or you might just see erythema of the tympanic membrane. But be aware that erythema is not necessarily diagnostic of acute otitis media. Redness can occur simply with stress or even blushing. Another important clue is that the tympanic membrane is immobile under positive pressure with a pneumatic otoscope. So you blow a little puff of air into the ear canal with an insufflator and you look for movement of the tympanic membrane, because if the tympanic membrane is immobile, that's an important criterion for the diagnosis of acute otitis media. So what are the bacteria that can cause acute otitis media? Strep pneumoniae is one of the big ones. It's the most common bacterial cause of acute otitis media. Non-typable Haemophilus influenza can do it, not the type B that causes meningitis. This is non-typable Haemophilus influenza. And then Moraxella catarrhalis. So those are the three most common bacterial causes of acute otitis media. And then what antibiotics do we use to treat acute otitis media? Well, you can use amoxicillin, you can use amoxicillin plus clavulanic acid, or you can use cephalosporins. And for kids with recurrent episodes of acute otitis media, you may need to place tympanostomy tubes to maintain and equalize pressure. And one of the complications to be aware of with acute otitis media is acute mastoiditis. So you should suspect acute mastoiditis in a patient with typical otitis media symptoms like fever and ear pain and irritability, plus post-auricular swelling and redness and tenderness of the mastoid process, that bony prominence right behind the ear. Another middle ear problem that shows up on step 1 from time to time is cholesteatoma. Cholesteatoma is overgrowth of desquamated keratin debris within the middle ear space that may eventually erode the ossicles and also the mastoid. So this is bad news. Now the name is kind of misleading. There's no cholesterol or lipids involved. They ought to call it a keratoma or something. And these aren't neoplastic or cancerous, so don't let the oma throw you. But these can be destructive and they can erode the ossicles. So what causes cholesteatoma? Well, there's negative middle ear pressure from eustachian tube dysfunction, and that negative pressure pulls on the tympanic membrane and creates a chronic retraction pocket. Or it could occur when there's a hole or perforation in the tympanic membrane and the epithelium grows through that perforation from the inside out. Now, cholesteatoma is commonly associated with chronic middle ear infection. On physical exam, you're going to see a grayish white or pearly lesion behind the tympanic membrane or possibly involving the tympanic membrane. And the patient may also have some conductive hearing loss or vertigo. Now, the first time I ever saw cholesteatoma, I looked in the patient's ear and I said, "What in the world is that? I don't know what it is, but it ain't normal." And I sent the patient to the ENT that day. The ENT recognized it and did surgery to remove it that same week. You don't want to mess around with these. So the treatment is tympanomastoidectomy with reconstruction of the ossicles. Let's talk about vertigo, which is a disorder of the vestibular apparatus. Vertigo is an illusion of motion, usually spinning or rotational movement. You'll see a lot of patients who complain of feeling dizzy, but dizzy is a fairly vague term. Sometimes patients will use the word dizzy to describe lightheadedness or presyncope, like they're going to faint. That's not really vertigo. Vertigo is a sensation of movement, like the room is spinning or like you're spinning. The most common cause of vertigo is something called benign paroxysmal positional vertigo, or BPPV. The precise etiology of BPPV is not entirely clear, but it's presumed that you either have debris in the semicircular canals of the vestibular apparatus or you have some otoliths that are misplaced. There are certain maneuvers you can do, like the Dix-Hallpike maneuver and the Epley maneuver, that can help you diagnose BPPV and then treat it. There are other peripheral things that cause vertigo, including vestibular neuritis, or inflammation of the vestibular nerve, or Meniere's disease, which is due to imbalances of the fluid and electrolyte composition of the endolymph, the fluid inside the vestibular apparatus. The classic triad of symptoms in Meniere's disease is intermittent vertigo, tinnitus, and hearing loss. Then there's also central vertigo, which is due to a brainstem lesion or a cerebellar lesion that damages the vestibular nuclei. Or posterior fossa tumors could potentially compress the cerebellum or the brainstem and cause some central vertigo. Now we're ready for the end of session quiz. Go ahead and pause the video, work through those. We'll go through them together. First question. Patient presents with vertigo, tinnitus, and hearing loss. What's the diagnosis? That's the classic triad of Meniere's disease. Next, which bacterial organisms are most commonly responsible for acute otitis media? We mentioned Strep pneumoniae, non-typable Haemophilus influenza, and Moraxella catarrhalis. Next, what bacterial organism is most commonly responsible for otitis externa? This is Pseudomonas aeruginosa. And the last one, chronic otitis media can sometimes result in a cystic lesion that's lined by keratinizing squamous epithelium, which could be metaplastic, that's filled with amorphous debris. What's the diagnosis? That's a cholesteatoma. That's it for now. I'll see you next time. Let's go over the warm-up review. First question, to which class of antiarrhythmics does each of the following agents belong? So we have verapamil, which is a class 4 antiarrhythmic, a calcium channel blocker. There's procainamide, which is a class 1, lidocaine, which is another class 1, and diltiazem is another calcium channel blocker, so it's also class 4. Next question, what's the clinical use for tiotropium? Tiotropium is an inhaled anticholinergic drug that's used to treat COPD. It helps to relax the airway so it opposes bronchospasm. And the last one, a patient has facial angiofibromas, ash leaf spots of depigmentation, a history of seizures, and intellectual disability. What's the most likely diagnosis? And what neoplasms is this patient at increased risk of developing? So this is a classic presentation of tuberous sclerosis. And the neoplasms these patients are at risk of include cardiac rhabdomyoma, astrocytoma, and angiomyolipoma. Now we're ready to move on to the lecture.
Whoa! Where am I?
You're dreaming.
Well, that's cool, I guess. Who are you?
I'm your subconscious.
Really? Didn't even know I had one.
Yeah, it's kind of in the name.
Ooh, can you tell the future?
What? I'm not a psychic, you moron. I'm just a part of your brain. And before you ask, no, I can't grant you 3 wishes. Hey, I can see what you're doing. It's not like you can hide from me. We are literally using the same brain.
Man, you're a real jerk.
I know you are, but what am I?
Whoa. All right, let's get on with the lecture. So let's talk about some sleep stages. Let's go through the different stages of our sleep. To this day, we actually don't know the purpose of sleep. We know what happens when we don't get enough sleep, but it's incorrect to think that sleep is a time period where the brain rests or becomes less active. The brain is doing some very complex stuff while sleeping. In fact, it goes through a very distinct stage group, and not only do we see different behaviors in each of these stages, but we see very distinct EEG patterns. So let's go through all of these. So first we have the awake stage. So your eyes are open, you're alert, there is active mental concentration going on. So this is characterized by beta waveforms on the EEG. Now remember, you need to know the EEG waveforms and how they correspond to the different stages of sleep. So remember, beta with the awake stage. Now, when you close your eyes and you're maybe meditating or just relaxing, but not sleeping yet, you go from a beta wave to alpha waves. So this is not quite stage 1 sleep yet. You're just kind of chilling out. And next we have the actual stages of sleep. So there are 2 main categories: rapid eye movement sleep, so REM sleep, or the non-REM sleep. And this is why the non-REM stages are often referred to as N1, N2, N3. That stands for the non-REM stage. So first let's talk about stage N1 sleep. So this is very light sleep. Here we see theta waves on the EEG. Now there are some books that might have stage 1 showing alpha waves. Alpha waves, remember, are seen in that kind of awake state just before sleep. You're chilling out. Make sure you know that stage N1 sleep, when you are actually asleep, shows theta waves. Now young adults will spend about 2 to 5% of their sleep time in that stage 1. Next, let's move on to stage N2 sleep. So this is a deeper sleep, and it's characterized by sleep spindles and K complexes on the EEG. Bruxism takes place in stage 2 sleep. So what is bruxism? So this is teeth grinding. Now one way to remember this is that you grind your tooth in stage 2. Now young adults will spend about 40 to 50% of sleep in this stage. So remember, sleep spindles, K complexes, and then 40 to 50% of the time young people are staying in that N2 stage. Moving on to stage N3. So this is slow wave sleep, or sometimes referred to as just deep sleep. Young adults are going to spend about 20% in stage N3. Now the waveform for stage N3 shows delta waves on the EEG. And it's actually kind of like the reverse of beta waves. Delta waves are low frequency, high amplitude waves. Stage N3 is where you have sleepwalking, night terrors, and also bedwetting. Now, what is the medical name for bedwetting? Remember, it's enuresis. Imipramine is a TCA drug. It's one medication used to treat nocturnal enuresis, and it does this by decreasing the stage 3 sleep. Now, imipramine is not first line, but it's still a treatment. Now, the time spent in stage N3 tends to decrease with age. Benzodiazepines and alcohol will also decrease stage 3 as well as REM sleep. And then we have our REM, our REM sleep here. All of the other stages are considered that non-REM sleep. Now REM stands for rapid eye movement, and REM sleep occurs at about 90-minute intervals and makes up about 20 to 25% of the total sleep. So here we have dreaming. Patients will also lose motor tone, and males can also have erections as well. Now sometimes this is called paradoxical sleep because the EEG shows beta waves. Where have we seen these beta waves before? Well, it was in the awake state. So the brain is using a lot of oxygen as well because this beta wave form of sleep is just like the awake state. Also in REM, we see a predominant parasympathetic state, so a vagal state. Also good to know that as well.
Now, the extraocular movements during REM, that rapid eye movement, are due to the activity of the PPRF, and that is the paramedium pontine reticular formation. Pretty much anything that has rapid horizontal eye movement is going to be mediated by that PPRF. So remember, beta waves, dreaming, and loss of motor tone for REM sleep. Now, for the first half of the night, you tend to go through all of the stages in order, meaning going from wakefulness to stage N1 to N2 to N3 to REM. Now, in the second half of the night, we tend to just kind of alternate between stage 2 and REM sleep. You're just kind of going back and forth between those two. So now we're going to move on to changes in sleep patterns, specifically in the elderly. So as we get older, we see significant changes to our sleep patterns. Generally, older patients will have decreased slow wave sleep, that deep N3 sleep, also decreased REM sleep as well. So what are you left with? Well, you're left with just stage 1 and stage 2. Elderly patients unfortunately stay in this lighter sleep through much of the night. They also awake more frequently throughout the night as well. So they have increased REM latency, which means it takes them longer to get to that REM sleep after they first lie down and close their eyes. So definitely know those sleep patterns in the elderly. And then we also have some different sleep patterns in depressed patients as well. So we see that altered sleep pattern here. So in depressed patients, we have decreased slow wave sleep, just like you do in the elderly, but the REM sleep is different. Depressed patients actually have increased REM, and depressed patients have decreased REM latency, which means that they get to REM sleep quicker. They'll have repeated nighttime awakenings and early morning awakening as well. All right, so let's do a rapid Lewis notes just to cement these in our minds. All right, everybody, welcome to another Lewis Notes, and we're talking about stages of sleep, and we're going to do a matching game here like we usually do, and we're going to put all the high-yield stuff where they need to go. So the first one we have here are the theta waves. Where do we see those theta waves? Remember, theta waves, we're in that light sleep. That's that stage N1. Bruxism, when people are really grinding those teeth, where do we put that? Remember, that's going to be in stage N2. Delta waves are super slow wave stuff. That's going to mean your deep, deep sleep in stage 3. Beta waves, where did we see the beta waves? Well, we saw them in 2 places, but one place that we saw them was in REM sleep, but we also saw them in the awake stage as well. What if you're just chilling out, relaxing? Where are you going to be? You're going to be in alpha wave territory. Sleepwalking, what are you going to do with your sleepwalking? Remember, sleepwalking, you're going to see that over here in stage N3, your deep sleep. You don't remember waking up and walking around. What about your sleep spindles and K complexes? That's going to be over here in our stage 2 again. Bedwetting, where are you going to see all your bedwetting? Again, that's going to be over here in stage 3. Losing all of your muscle tone. Remember, that's going to be in your REM sleep, especially if you remember people with narcolepsy, when they just fall down without any muscle tone. That's because they're going straight into that REM sleep. And then where are we going to find our lovely dreams? We're going to find our lovely dreams over here in REM sleep again as well. All right, guys, so that's going to be it for our Lewis Notes. So now let's move on to some common sleep disorders. So insomnia is our first one here. Very, very common. Some resources say somewhere between 30–40% of the U.S. population. This could be even low. It might be even closer to 50 or even more will have problems with insomnia. And now we're going to go over most of the medications that are associated in the treatment for insomnia. So which one of these are we going to use? What makes them unique? So the first one here is going to be melatonin. So melatonin, a nice non-addictive med. It's over the counter, pretty good safety profile. It's hard to hurt yourself with melatonin, but there is questionable efficacy. We're not really sure if it really works. Antihistamines, diphenhydramine, very commonly used. It's over the counter. It's in a lot of the over-the-counter sleep aids. You probably do want to avoid this in the elderly. That can lead to a delusional behavior. You can also get a lot of next-day fatigue if you're using those drugs as well. Antidepressants, amitriptyline, trazodone, doxepin, these work through anticholinergic effects. Unfortunately, that might give you more side effects. Think of dry mouth, constipation, that type of stuff. Benzodiazepines, triazolam, timazepam, lorazepam, diazepam, there's a lot more of those. Those are going to increase GABA activity. Unfortunately, they're very addictive. You should really only use these for short term. Zolpidem, Zaloplam. These also act at the benzo receptor a little differently than our benzodiazepines. You're supposed to use these only for short term, but they are used pretty long term for a lot of patients. You can also get rebound insomnia when discontinued, but they're not very addictive. Izopiclone is actually very similar to Zolpidem and Zaloplam. They do have this one does have a longer half-life, good for sleep maintenance. It could be used a little bit longer term as well. Ramelteon, Non-addictive because it works at melatonin receptors instead of our GABA benzoreceptors that we've been talking about previously. You want to avoid these if there's hepatic insufficiency. Long-term studies are lacking though. Now, one extra bit of info on Ramelteon is that it can be used safely in geriatric patients. Some of the other meds can lead to altered mental status in the elderly, but Ramelteon is relatively safe. Another group, orexin receptor antagonists. So suvorexant is the example there. So orexin A and B are neuropeptides that promote wakefulness. So these drugs are not promoting sedation like all these other drugs. They're actually just blocking wakefulness. So they can be kind of a different way of treating this. So now let's move on to restless leg syndrome. So this is where you have the sensation of kind of unpleasant sensations that compels the patient to kind of want to move their legs, kind of the creepy crawlies. So this occurs during times of inactivity, and the movement temporarily relieves those symptoms. Now usually this is a primary idiopathic disorder. We don't know why it happens, but there can be some secondary RLS, things that can result from iron deficiency, end-stage renal disease, diabetic neuropathy, Parkinson's disease, pregnancy, rheumatic diseases like RA, varicose veins as well. Also just things simple like caffeine intake. Treatment, first always check iron stores, replace iron if needed since that's pretty common. Next you can use a medication, pramipexole or ropinirole. You can give those at night. If patients have comorbid pain, then you might want to consider things like gabapentin or pregabalin. Moving on to night terrors. So these are periods of terror with screaming in the middle of the night. This is more common in children, and they occur during non-REM slow wave sleep, so that's stage N3. So remember that regular dreaming occurs during REM sleep. So these are not just bad dreams. There is no memory of waking up in these patients. It's actually very difficult to wake them up from a night terror because they are actually in a slow wave sleep. Patients won't remember walking around or speaking or doing anything weird. Benzodiazepines can be used to decrease stage 3 sleep and thus potentially decrease night terrors overall. Next, we have obstructive sleep apnea. So sleep apnea is where you have collapse of the airway during sleep, which obstructs the airway so that patient can't breathe. Now, this may be REM related, where you get that muscle atonium that impairs airway patency. There's also an anatomy component because we see this in obese patients, especially those with very short, thick necks. The primary treatment for obstructive sleep apnea is going to be CPAP. We also encourage weight loss as well. Moving on to narcolepsy. So patients have excessive daytime sleepiness. These patients, when initiating sleep, and this is important, will go straight to REM sleep without going through any of the non-REM stages. And it can result in hallucinations and cataplexy, so sudden loss of muscle tone. And it actually makes a lot of sense because we just learned that REM sleep is where you dream a lot and where you lose all your muscle tone. So you go from being awake to, boom, dreaming without any muscles. All right, so let's talk a little bit more about the treatment for narcolepsy in the study guide here. So avoidance of drugs that cause sleepiness is definitely important. Scheduled naps can help narcoleptic patients as well. Stimulants like modafinil are first line. They are a form of amphetamine, but they are a bit less addictive. You can still try some of the other stimulants like methylphenidate if modafinil is ineffective. Another strategy to prevent cataplexy is to use medications that suppress REM sleep. So these include venlafaxine, fluoxetine, and atomoxetine. Sodium oxybate may also be used if there's a lot of cataplexy involved. Next, we have nocturnal enuresis. So this is bedwetting. So first, at what age should nocturnal enuresis be treated, and then what are the treatment options? So enuresis cannot be diagnosed until 5 years of age, both chronological and developmental age. Treatment is usually delayed until a patient is at least 7 years of age. Behavioral interventions can be attempted like decreasing fluid intake, positive reinforcement. None of those have been shown to work very well. Enuresis alarms have the best success rate, so a horrible alarm goes off every time they pee and it kind of wakes them up and kind of conditions them to not want to pee. There are some pharmacologic interventions. The problem with these is that there's a high likelihood of recurrence upon discontinuation. So you stop the med, they start peeing again. Desmopressin, also referred to as DDAVP. This is given orally. So what is this? Well, this is just anti-diuretic hormone. So what does that do? Well, it causes antidiuresis. So it decreases the need to urinate. And this is usually used first line, but again, as soon as you stop the med, the enuresis generally returns. Imipramine is a TCA that decreases the time spent in stage N3 where bedwetting generally occurs. It can only be used for short term, maybe up to 6 weeks. Indomethacin is another option. What does that do? Well, it decreases renal blood flow. So by decreasing renal blood flow, you're going to decrease your glomerular filtration rate. You're not going to make as much urine, and that's going to decrease urine output so you don't pee on yourself. All right, guys, that brings us to the end of our lecture part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. First question, what EEG waveforms correspond to the different stages of sleep? So good to remember this one. So stage 1 has the theta waves. Stage 2 is your deeper sleep. That's where you see the sleep spindles and K complexes. Stage 3 is your deepest sleep with low frequency, high amplitude delta waves. And then the REM sleep shows those beta waves, just like the awake state. Next, what drugs are used to shorten stage 3 sleep? So you can use imipramine. You can also use benzodiazepines. So these can be given for enuresis and for night terrors and sleepwalking, all of which take place during stage 3 of sleep. Next, what is the sleep pattern in a patient with narcolepsy? So remember that patients will rapidly transition from the awake state to the REM sleep, which can result in that cataplexy and even hallucinations. Next, during which stage of sleep do night terrors occur? Mostly in stage N3. Remember, this is not REM sleep, therefore they are not just typical nightmares. All right, guys, that brings us to the end of our lecture here. Well, subconscious, how did we do?
I have no idea. I was busy repressing the memory of the time that you had that wardrobe malfunction at the prom.
Dude, ixnay on the empre. All right, now, time for my wishes.
Idiot.
Let's go through the answers to the warm-up review. First question, what's the classic presentation of amyotrophic lateral sclerosis, or ALS, sometimes known as Lou Gehrig's disease? Well, ALS causes both upper and lower motor neuron deficits with no sensory deficits. And then the last question, what are the classic signs of an upper motor neuron lesion? So with an upper motor neuron lesion, you're going to see spastic paralysis and hyperreflexia. And then with a lower motor neuron lesion, you're going to see flaccid paralysis, muscle atrophy, and fasciculations. All right, let's get started with the lecture.
Hello everyone and welcome to our Step 1 video on anesthetics. It's time to turn down your propofol drips and pay attention. Let's get going. All right, so in this video we're going to talk about anesthetics, and there are 3 big groups of anesthetics that we're going to talk about today. Inhaled anesthetics, IV, and then local. Now, there are 3 main components to general anesthesia. There's amnesia, analgesia, and immobilization. Now, amnesia means the patient has no memory of the surgery, no memory of being intubated and prepped or any other events related to the procedure, so they are knocked out. Analgesia means pain control. So surgery is painful, we're cutting them open, you don't want them to feel that pain. And then immobilization or paralysis is important because in order to perform a procedure correctly, you need complete immobility in that working area. So as we talk about anesthetics, we'll talk about how different drugs achieve these different aspects of amnesia, analgesia, and immobilization. Now first, let's go over some basic pharmacological principles about inhaled anesthetics. So in order for an inhaled anesthetic to work, it must be able to cross the blood-brain barrier and get into the brain. So there are 2 characteristics of each inhaled anesthetic that you need to consider: lipid solubility and blood solubility. Now, the higher the lipid solubility, the easier it is for that drug to get into the CNS, into the brain, so you can get more effect with less drug. So the higher the lipid solubility, the more potent the drug is. So you can achieve anesthesia at a lower concentration. Now, blood solubility affects the amount of time it takes for a drug to start working, and drugs with low blood solubility will have a rapid onset of action. So I think of this as not getting stuck in the blood or getting mixed in with the blood, being able to move out of that blood into the brain more easily. And then the next concept to discuss very briefly is the MAC, the minimum alveolar concentration. So the MAC is the concentration of inhaled anesthetic that is needed to prevent movement in 50% of patients after a painful stimulus. So how much does it take to get 50 of those people to be knocked out? All right, so now let's use these concepts and look at some inhaled anesthetics. So inhaled anesthetics are used very commonly for both the induction and maintenance of general anesthesia, and that induction is just getting them asleep, and then maintenance is obviously keeping them asleep. Now the precise mechanism of action of these drugs is still really not fully understood. We know that they affect multiple things in the CNS like GABA, like glycine, like glutamate. Nitrous oxide is thought to work primarily by blocking NMDA receptors. So let's go through a few of these in more detail. So first, let's talk about nitrous oxide. It's been used for a long, long time. It enters the brain rapidly because it is very insoluble in the blood. So it has no trouble getting out of the blood and into the brain. Nitrous oxide has a rapid induction and a rapid recovery time. It gets in and out of that brain very quickly. However, nitrous oxide is not very lipid soluble, and as we said before, this makes it less potent. It's not a very strong medicine. Now, nitrous oxide is not used alone very often, but is often used in combination with other inhaled anesthetics like sevoflurane or isoflurane. Let's move on to halothane, the granddaddy. So halothane, on the other hand, it's going to be more soluble in the blood, which means it's less of it is going to be available to the brain. So it takes longer for it to reach the desired effect, and it takes longer to recover. Now, there's also a risk of hepatotoxicity with halothane, so halothane is almost never used anymore. Now, desflurane and sevoflurane are the potent inhaled anesthetics with pretty similar solubility profiles to nitrous oxide. Now, sevoflurane is used very often, especially for induction of anesthesia, and overall it's probably the most used inhaled anesthetic. And then in the middle of the road is probably isoflurane. It has a slower induction and recovery compared to sevoflurane and desflurane, but much faster than halothane. Let's move on to our IV anesthetics. So IV drugs used for anesthesia, which include medications that are referred to as sedative hypnotics most of the time. So these drugs induce a state of complete unconsciousness, but do not provide analgesia very well. So this would include drugs like propofol, thiopental, adjuncts like the benzodiazepines as well. So let's start with propofol. So everybody has heard of propofol since the death of Michael Jackson. Now it's sometimes called milk of amnesia because it kind of has a milky white liquid substance look to it. Now, propofol is an IV induction agent that works by increasing GABA in the CNS, so much like the benzodiazepines. Now, it's an extremely popular drug to induce anesthesia because of its rapid onset. It works within about 15 to 20 seconds, so super fast. Now, after that initial induction dose, it redistributes from the brain to the rest of the body, and then its effect starts to wear off over a period of about 5 to 10 minutes. But if you start an IV propofol drip, you can also use this drug to maintain anesthesia. Now, propofol has a rapid recovery due to that rapid distribution. It's getting into the brain very quickly, and then it's going to redistribute to the rest of the body quickly. It also very rapidly metabolizes to an inactive metabolite by the liver. Therefore, when you stop that IV maintenance infusion, its effect is going to wear off within about 20 to 40 minutes. Now, another thing to know about propofol is that it has a very high triglyceride content. So you wouldn't want to have a patient on propofol drip for days and days and days. Now, you might have a patient in the ICU that's on a ventilator on propofol for maybe a day, maybe two, but any longer than that, you're going to tend to elevate the triglyceride levels, which is going to increase their risk for acute pancreatitis. Let's move on to ketamine, another medication that we need to be familiar with. Ketamine is actually a PCP analog, and it's used for a variety of things, including analgesia, conscious sedation, induction of general anesthesia as well. Now, it's commonly called a dissociative anesthetic, where the patient actually kind of seems to be awake and aware, but is totally disconnected to the outside world. Now, at high doses, it may cause hallucinations as well. Now, this is more problematic in adults than in children. Children tolerate it a little bit better. Now, at low sub-anesthetic doses, it does provide analgesia without the severe hallucinations or those real vivid dreams that are also associated with ketamine. And you should also know that ketamine increases cerebral blood flow as well. Now, barbiturates, on the other hand, tend to decrease cerebral blood flow, which makes them useful for brain surgery, where a decrease in ICP is often important. And speaking of the barbiturates, let's talk about them in a little bit more detail. And we'll also compare them to benzodiazepines. They're kind of similar, but a little deceptive there. Now, a lot of barbiturates have the suffix barbitol, like phenobarbital, pentobarbital, secobarbital. There's also one called thiopentol as well. Now, all of these work by acting on the GABA receptors in the CNS. Now, GABA, as you probably already know, is the primary inhibitory neurotransmitter of the CNS. Now, the GABA receptor has a chloride channel, and when GABA binds to its receptor, the channel opens and chloride ions are going to flood into the postsynaptic neuron and stabilize the membrane potential, making it harder to produce action potentials. Now, barbiturates are going to work by keeping those chloride channels open longer. They increase the duration of that GABA receptor chloride channel staying open, and that facilitates the inhibitory effects of GABA. And when you inhibit the brain, you're causing sedation. They can also be used as sedatives to decrease neuronal firing and lots of other scenarios as well, like even seizure disorder. Now, sedation and CNS depression can also cause a lot of side effects. It's going to look a lot like someone who's been drinking a lot, who are drunk. They're going to be kind of sluggish. They might have an ataxic gait, maybe even double vision. So how do we treat an overdose or a toxicity of barbiturates? Well, there's actually not a great antidote or reversal agent to treat barbiturate toxicity. We simply have to treat it symptomatically and keep people alive. Now, one other interesting use of phenobarbital, which we'll probably discuss in the GI videos on the hepatobiliary system, is that phenobarbital can increase liver enzyme synthesis, also known as enzyme induction. And that can be useful in treating something called Crigler-Najjar syndrome type 2, where the liver is deficient in the enzymes needed to process bilirubin. So by giving phenobarbital, you can ramp up the production of those enzymes. And we'll go into that more detail in those videos. So now let's compare barbiturates to benzodiazepines, which we actually use a lot more often, because they are both used for sedation and anesthesia, and they work in similar ways. Now, there are tons of different benzos out there, and most of them end in either azepam or azalam. So there's diazepam, there's lorazepam, alprazolam, there's a ton of them. Now, midazolam is one that is very commonly used for conscious sedation in short procedures. So remember midazolam, or you can also use it to sedate someone before you take them to the OR and start that general anesthesia. Now, there are longer-acting benzodiazepams like temazepam, often commonly used for insomnia. It lasts a little bit longer. Also a good nighttime interval dosing. Another long-acting one that's classically used for alcohol withdrawal is that chlordiaze epoxide. So again, benzodiazepines have a very similar mechanism to the barbiturates, but there is a difference. Instead of increasing how long the GABA receptor chloride channels stay open, they increase how frequently the chloride channels open. But the end effect is actually the same. Now, you're potentiating GABA and increasing the effect of that inhibitory neurotransmitter. And though it's a bit on the sexy side, many students have written in with a mnemonic, Ben likes it more frequently, Barb likes it to last longer. Just another way to remember, barbiturates increase the duration, benzos increase the frequency of chloride channel opening. Another one that I personally like a little bit better is that people like the bars to stay open longer. So bars, barbiturates, that sort of thing. Now, benzos are really useful in anesthesia because in addition to some sedation, they cause amnesia as well. So we said that this was one of our 3 goals of anesthesia, amnesia, analgesia, and the immobilization. You don't want patients to have any memory of what's going on during surgery because it's kind of scary. But besides conscious sedation and anesthesia, we use the benzodiazepines for a lot of different things. We use them for alcohol withdrawal, anxiety, to stop seizures, to help with insomnia. But you should also know that while these drugs do help patients feel drowsy, essentially they're going to sleep, it's actually not permitting the normal brain activity of sleep. If you were paying attention during that sleep lecture, you remember that benzodiazepines decrease stage N3 of sleep, which can actually be pretty helpful if you want to decrease sleep terrors. Now, one problem with benzodiazepines is that they can be abused, and there's a big problem with dependence and addiction, and you don't want to mix benzodiazepines with alcohol or other sedatives. But actually, they are generally a lot safer than the barbiturates overall. It's pretty hard to put yourself into a coma or even kill yourself with benzodiazepines. but you definitely need to know this. What is the reversal agent for benzodiazepine toxicity? The reversal agent is flumazenil. However, clinically, we don't use this very often because flumazenil might actually trigger a withdrawal seizure, especially if that patient has been abusing benzodiazepines for a long period of time. Most of the time, we just allow the effects of benzos to wear off. So next, let's move on to opioids. Now, we said that we use benzos to sedate our patient and cause some amnesia. And then the second component of anesthesia is analgesia, or pain control. Now, we typically give opioids to achieve appropriate levels of analgesia, especially the potent IV opioids, things like morphine. We're using even more things like fentanyl, remifentanil, and sufentanil. And that's going to prevent the patient from experiencing any of that pain. So for conscious sedation, you might give midazolam plus maybe fentanyl. Mixing a benzodiazepine with an opioid analgesic, they're going to act synergistically. They provide a higher degree of sedation than if their effects were alone. Now, the opioids work by binding to opioid receptors. Now, the three receptors you should know are mu, delta, and kappa. Now, our bodies actually produce endogenous agonists to these different receptors, and you should probably know those as well. So at the mu receptor, beta endorphin is the agonist. At the delta receptor, you have enkephalin, that's going to be your agonist. And at the kappa receptor, it's going to be dynorphin. Now, one quick thing to know about fentanyl is that it doesn't induce the histamine release like morphine does. So morphine can sometimes cause a histaminic reaction. They get really, really itchy, and fentanyl really doesn't do much of that. Now, there are a few other unique opioids that aren't used in anesthesia, but you should probably know about them. So those butorphanol, that is a partial opioid agonist that causes less respiratory depression. We have dextromethorphan, a very, very weak opioid that's used as a cough suppressant, and it's over the counter. Tramadol is a less addictive opioid that can be used for pain. And then loperamide and diphenoxylate are used in the treatment of diarrhea, so they can really dry people up. Also important to remember that opioids can be reversed with the opioid receptor antagonists, naloxone and naltrexone. All right, so now let's move on to the neuromuscular blocking agents. So we've covered the amnesia, and we've covered some of the analgesia, and now that third component, we need to get immobilization going here. So to ensure immobility, we use a neuromuscular blocker. Now these drugs induce a state of chemical paralysis and should only be used in a patient who is unconscious because paralyzing conscious patients would be really, really frightening and dangerous. We also use neuromuscular blocking agents to facilitate endotracheal intubation as well. Now, there are two different categories of neuromuscular blocking agents. There are the depolarizing neuromuscular blockers, and there are the non-depolarizing drugs. Now, there's only one depolarizing neuromuscular blocking agent in clinical use, which is succinylcholine, but there are several different non-depolarizing drugs, so let's start there. So the non-depolarizing drugs are chemically related to a plant poison named curare. So this poison was used by indigenous peoples of South America by dipping arrows or blow darts into them, and then the prey, after it was shot, would have respiratory muscle paralysis, and then they would just die. So these drugs all sound like they come from curare. So there's one called tubocurarine. Some actually have a suffix curium, which includes the drugs like atracurium and mivacurium. And then there's another suffix, curonium, which include drugs like vecuronium, rocuronium, pancuronium. Now, each of these drugs is used at different times for different reasons, but be able to recognize the three suffixes, that curarine, curium, and curonium. Now, how do these work? Well, these are competitive inhibitors of the postsynaptic nicotinic acetylcholine receptors on the neuromuscular junction. So they compete with acetylcholine for that binding site. And when they bind to the receptor, they actually prevent acetylcholine from triggering a muscle contraction. So the muscle just stays nice and relaxed. But think about this for a second. How do you overcome a competitive antagonist? Well, you can increase the amount of natural agonists. So you can actually reverse a non-depolarizing neuromuscular blocker like rocuronium by giving a cholinesterase inhibitor, something like neostigmine, which will effectively increase the amount of natural acetylcholine at the neuromuscular junction. You're kind of overdriving it. The other big category of neuromuscular blocking drugs is the depolarizing neuromuscular blocker. And we said there's only one of those, succinylcholine. So how does it work? Well, succinylcholine is going to bind to those same nicotinic receptors on the neuromuscular junction. So it's also a nicotinic agonist, so to speak. But the difference is that instead of just preventing acetylcholine from triggering a muscle depolarization, the succinylcholine actually does stimulate those nicotinic receptors. So the muscle does depolarize and you actually get a contraction. Now clinically you're going to see some muscle movements called fasciculations. Now after an appropriate dose, those fasciculations will cease after just a few seconds, and then as the succinylcholine molecule remains bound to the acetylcholine receptor, neuromuscular blockade is actually achieved until that succinylcholine molecule moves away from the acetylcholine receptor and then is degraded by serum pseudocholinesterase. So this takes maybe about 10 minutes. Now, succinylcholine can cause two different types of block, which are clinically important. There's something called a phase 1 block. So this is a type of block that you get when you administer an appropriate dose to a normal patient. And a phase 1 block has a very rapid onset, goes away in again about 10 minutes, just as mentioned. Now, a phase 1 block cannot be antagonized and has very unique characteristics when using a twitch monitor to verify the degree of muscle relaxation in a patient. If a patient receives a large dose of succinylcholine, you can get a phase 2 blockade. Now this block has characteristics that are very similar to those of non-depolarizing muscle blockers, and a phase 2 block can also be antagonized by using acetylcholinesterase inhibitors, things like neostigmine. Importantly, a phase 2 block can last from 20 to 30 minutes up to a few hours. Then one last thing to mention about succinylcholine is that the potential for malignant hyperthermia. So malignant hyperthermia is a condition where you have muscle rigidity and hyperthermia, so high temperature. Now if you give an inhaled anesthetic with succinylcholine to a susceptible patient, specifically a patient with a mutation of the RYR1 gene, which is a gene for skeletal muscle ryanodine receptor. So if they have that mutation, then the succinylcholine can cause malignant hyperthermia, and it's pretty rare, but unfortunately pretty dangerous. So if you have a patient with a history of malignant hyperthermia, you would avoid using succinylcholine in the first place. You'd reach for a non-depolarizing neuromuscular blocking drug instead. But if you did give succinylcholine and they did actually get this problem, then your treatment is to cool that patient down. You're going to sedate them, and then you need to give them dantrolene. And you're going to give that dantrolene as quickly as possible. Dantrolene is a drug that prevents the sarcoplasmic reticulum from releasing calcium, and that's going to lead to more relaxation of the muscles. Now we use it also to treat malignant hyperthermia and also neuroleptic malignant syndrome, which is somewhat similar as well, and it's covered in psychiatry. All right, so that's it for the neuromuscular blocking drugs and the general anesthetics. Now let's talk briefly about the local anesthetics. So local anesthetics, whether it's things like lidocaine, procaine, even cocaine, they all work by blocking sodium channels. So sodium channels are the workhorses of the neurons, allowing them to depolarize and fire. Blocking these channels impedes the ability of neurons to reach their threshold and then fire off. But there are a few important concepts to understand about local anesthetics. So first of all, they don't all work very well in acidic tissues, and that includes things like infected tissues. So if you're draining an abscess with a scalpel and you're trying to open it up and you're trying to anesthetize the area, then you want to inject a local anesthetic, maybe a small distance from the infected tissue, or just use a lot more of it, which again has an acidic pH. The acidity of that infected tissue ionizes the local anesthetic molecule, making it unable to pass through the neuron cell membrane and thus unable to bind and block that sodium channel. Now, another principle of local anesthetics is that small diameter nerve fibers and myelinated nerve fibers are more susceptible to them than are the large diameter and the unmyelinated fibers. And the size is more important than the myelination. So the first thing you're going to block are the small myelinated fibers, then the small unmyelinated fibers, and then the large myelinated fibers after that. Now, so it turns out that sensory fibers tend to be the small diameter nerve fibers, and clinically this results in the ability to block pain at low dosages there. Now, the sympathetic nervous system contains medium-sized nerve fibers that are myelinated and require slightly larger doses to see a full block there. Now lastly, motor nerve fibers are the largest of all and are very myelinated as well. Therefore, clinically, in order to get complete motor block, you need a much larger dose than you would in order just to get a block of pain neurons. Now, the other principle of using local anesthetics is that we tend to give them with a local vasoconstrictor in certain parts of the body. You wouldn't want to give this in something that is a terminal organ. You don't want to give this in fingers where there's no collateral circulation because you can cause ischemia. But in tissues that have collateral circulation, you can give a vasoconstrictor such as epinephrine with your local anesthetic. And the reason why you would do this is to decrease the rate at which the blood carries the lidocaine away and to decrease bleeding at the site as well, because they're going to be cutting into it. So if you give lidocaine with epinephrine, the epinephrine will make those local vessels kind of clamp down and you're decreasing blood flow to the area. So you won't need as much anesthetic and it will last longer in that area as well. All right, that's it for the lecture part. It's time for that end of session quiz. Try to answer those questions on your own and then we'll go through them together. All right, first question, which anesthetic fits each of the following descriptions? So first we have IV associated with hallucinations and bad dreams. That's going to be ketamine. Next we have IV, most commonly used benzodiazepine for conscious sedation. Think midazolam. Next we have inhaled side effect of hepatotoxicity. Remember that one is halothane. We don't use that one anymore. IV for rapid anesthesia induction and short duration of action. Remember that's going to be propofol. IV decreases cerebral blood flow, important in brain surgery. That one might be a little bit tough for you. That's going to be that barbiturate thiopental. Next, we have opioid that does not induce histamine release. That's fentanyl, not quite as itchy. And high triglyceride content increases the risk of pancreatitis with long-term use. That's going to be propofol. Next question, what is the mechanism of action of dantrolene? So remember the dantrolene is going to prevent the release of calcium from the sarcoplasmic reticulum of that skeletal muscle. It's going to relax those muscles. Next, what is the mechanism of action of local anesthetics? Remember they block the sodium channels, and then which nerve fibers are blocked first with that local anesthesia? Remember it's the small myelinated, often pain ones, and then the small unmyelinated, then the large myelinated, and then the large unmyelinated. Next, last one here. What drugs can we use to reverse neuromuscular blockades? Remember, it's the cholinesterase inhibitors. Things like neostigmine is the prototype drug that's used for this. And remember that only for neuromuscular blockade with a non-depolarizing drug like tubocurarine or vecuronium. All right, guys, that brings us to the end of our video here. I hope you learned something. I'll see you next time.